Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening and good morning to everyone. On behalf of Saudi Society for Rheumatology and in partnership with the American College of Rheumatology, it's our great pleasure to welcome you on the last day of the Best of ACR Convergence 2020 Saudi Arabia. We have been with you for 3 days, where many of scientific and highest quality lectures were presented. We hope that you enjoyed in the previous meetings and also you get a scientific benefit by recognize the last and update topics at ACR Convergence 2020, which can improve the standard and the quality of patient care. Also, I'd like to invite you to visit and explore a wonderful 3D exhibition hall. Finally, if you don't mind, I'd like to remind you to fill the questionnaire after each lecture, which you can see it at the bottom of the screen. With no further delay, it's my honor and a pleasure to introduce the chairperson for the next sessions. He is Dr. Mohammed Dewi. Dr. Dewi, he's a consultant rheumatology, assistant professor and head of rheumatology unit at King Saud University. He had clinical research fellowship in general rheumatology, ankylosing spondylitis and psoriatic arthritis from University of Toronto, Canada. He is a board member in Saudi Society for Rheumatology. Also, he is a member of Assessment of Spondyloarthritis Society (ASAS) and member of a group of research and assessment of psoriasis and psoriatic arthritis. He had several publications in his field. I'd like to welcome you again, Dr. Mohammed, and the mic is yours.
Thank you very much, Dr. Fahid. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. Actually, I would like to thank the Saudi Society of Rheumatology for this very well structured and organized event. And many thanks again for bringing to us this best of ACR in this very beautiful way, presented with very distinguished speaker from international speaker and local speakers from Saudi Arabia. Special thanks for Dr. Hanan Rais and Dr. Fahid Al-Anizi and for this great effort, and to the other member in the organizing and scientific committees. So today we will have a very special session. We will have spondyloarthritis session with two distinguished speakers. First speaker is Prof. Suzanne Attar and the other speaker is Dr. Albert Enman. So our first talk will be about the best spondyloarthritis abstract presented in the ACR, which will be presented with our remarkable teacher and speaker, Professor Suzanne Attar. I think Prof. Suzanne is well known to us. And Prof. Suzanne is a professor of medicine and rheumatology at King Abdulaziz University in Jeddah. Prof. Suzanne is a board certified at Royal College of Physicians and Surgeons of Canada, and she's a fellow of the American College of Rheumatology. So Prof. Suzanne has published many landmark articles in rheumatic disease in Saudi Arabia, and she had great contributions in establishing and improving the rheumatology care in Saudi Arabia. So without further delay, I would like to give the mic for Prof. Suzanne Attar and to enjoy the next session about the abstract and spondyloarthritis. So please, Prof. Suzanne, mic is yours.
Bismillah wa salatu wa salam ala Rasulillah Sayyidina Muhammad Ashraf al-Anbiya wal Mursaleen. I would like to thank the Saudi Society of Rheumatology as well as the ACR for inviting me to talk about the ACR update in SPA, which is a topic that is close to my heart. Now, when I went over all the abstracts that have been presented at the ACR with regard to the SPA, I was amazed with the number and the quality of the abstract. But I tried to choose the ones that may have an influence on our practice. I have nothing to disclose, and I would like to thank the people who made this presentation possible with their name displaced. So we're going to go over some of the treatment management in the form of the JAK inhibitors, the IL-17, IL-23, the monitoring, and finally the pregnancy. JAK inhibitors that have been evaluated for the treatment of SPA include tofacitinib, filgotinib, and upadacitinib. Tofacitinib currently is the only JAK inhibitor that is approved for the treatment of psoriatic arthritis. Filgotinib and UBA are under investigation. There's no JAK inhibitor that have been approved for the treatment of AS yet. All the three, tofa, filgotinib, and upadacitinib, are under investigation. So let's go over the first abstract, which talk about the efficacy and safety of tofacitinib in active ankylosing spondylitis patient, which showed it was a phase 3 double-blinded placebo-controlled trial in which the patient, they were classified into 80% biological DMARD naive and 20% they were TNF inhibitor inadequate respond. There are two arms, the tofa, the 5 milligram BID, and the placebo that included 136 patients. The duration of the study was about 48 weeks, and the primary endpoint was at 16 weeks. The baseline disease duration was 13 years, and the ASDAS at the baseline for the TOFA 3.8 versus 3.9, that is considered to be a high disease activity. The endpoint that was at week 16, the primary, the ASAS and its components, the secondary, the ASAS 40 with the safety. So in the bottom figure, you could see that tofacitinib 5 milligram BID was a higher response than the placebo. That's the primary endpoint, as well as within the secondary endpoint, that is the ASAS 40, the key secondary endpoint. Now, when you look at the response over time, it was consistent, the highest response being at week 2, and it's consistent all over the time until the end of the study, which is the week 16. By looking at the family component of the primary endpoint, that is the ASAS, all the aspects, that is the patient global assessment, the total back pain, the PAS-Phi, and the morning stiffness, the response was higher in the treatment group than the placebo that was statistically significant. Now let's look at the safety profile, which was consistent with RA and PSA. There was no potential safety risk that they were identified. No malignancy, no thromboembolic events, no major adverse cardiovascular events or GI perforation. But the herpes zoster was higher in the tofacitinib group up to week 48, that is in the double-blinded and the open-label phase. So what did we learn so far from this trial? That is at week 16, the response by the ASAS 20, the primary endpoint was achieved. The patient-reported outcome, which was part of the ASAS in the form of the patient global AM stiffness, the PAS-Phi, and the back pain, was significantly improved, but there was no comment on any radiological component. The second abstract is the upadacitinib efficacy and safety in active ankylosing spondylitis patient. 1-year result from a randomized double-blinded placebo-controlled trial with open label extension, select access. Now, the study included two parts. The first part in the left side, that is period 1, 14 weeks, double-blinded placebo-controlled between placebo and Ubada 15 milligram once a day, and biological DMARD naive, in which they have a high disease activity at the baseline by the BASDAS 6.5, ASDAS 3.6. And this have been published in the Lancet in 2019. And it showed that the primary endpoint, which is the ASAS 40, statistically significant in the UBA group in comparison to the placebo group, as well as when you look at the MRI changes for both the spine and the sacroiliac joint assessed by the SPARC criteria, they were statistically significant in the UBA group versus the placebo. Now, let's move on to the period, to the period 2 result, which is the UBA effective in AS over 64 weeks. As you notice that the changes it was consistent and it was very quick in the first 2 weeks, and it persisted through the study period until week 64. Now, the placebo group that they were switched, again, they were switched to the treatment route, they catch up very quickly. And as we can see, within that time, even the patient global assessment and the PASV was significantly catch up and statistically significant. If we looked at the safety through 1 year, there's no serious infection, no active TB, no VTE, no major adverse event, and even the GI perforation that they were worried about in the beginning with the emerging of the JAK inhibitor, and there were no deaths as well. But there was one common side effect with regard to the UBA group, that is a transient increase in the CPK in comparison to the placebo. But as I said, it was transient and it wasn't associated with any clinical significant myopathy. So at week 64, the disease activity, that is a primary endpoint, SAS40, was significantly better. And the patient-reported outcome in the form of the pain, the PASV, and the patient global assessment as well improve. And as we saw within period 1, there is a significant MRI changes for both the spine and the sacroiliac joint. What about in patients with active psoriatic arthritis? The select PSA1 in non-biological DMARD inadequate response. There were 2 periods, period 1 and period 2, and I'll focus on period 1, in which the primary endpoint was at week 12. It contained the UBA treatment group, 15 milligram versus 30, and the adalimumab, as well as the placebo. Now, the secondary endpoint is quite exciting. At week 16 and week 24, they were looking at the MSK symptoms, the ACR20, non-inferiority and superiority versus adalimumab, skin changes in the form of the PASI 70, 90, and the 100, which is almost clearance of the skin. The patient-reported outcome, the function, and the pain and the fatigue, assessed by the reported measures, and as well as the radiographic progression in the MTSS score. So the results as the follow. The upadacitinib 15 milligram and the 30 milligram was superior to the placebo for the ACR20, and the UBA 15 milligram was not inferior to the adalimumab for the ACR20, but UBA 30 was superior to the adalimumab for the ACR20. And you could see that the response was picked up at week 2, and then it was consistent through all over the study period. And in the bottom, there's a change from the baseline radiographic MTSS score. So all the parameters and the MSK symptoms, the skin, the patient-reported outcome, as well as the radiographic progression had shown improvement. What about the adverse event through week 24? As you can see, with regard to the serious adverse event, the serious infection and the herpes zoster, it's in the UBA 30 milligram once a day, which is not the recommended dose for the treatment. But the VTE, the UBA, the higher dose, was consistent with the placebo. So what did we learn so far? That the JAK inhibitor have a potential role in SPA. In AS, in biological DMARD naive, TOFA 5 milligram achieved SAS20 at week 16, UBA 15 milligram achieved SAS40 at week 14, and as well as the bioradiographic, the MRI of the spine and the SI joint. In PSA, in the conventional DMARDs, inadequate response, the UBA 15 milligram at week 12 was superior to the placebo and non-inferior to the adalimumab. Now let's move on to the IL-17. Now in psoriatic arthritis, the main domain, we know that there are 6 main domains involved: joint damage, skin involvement, enthesitis, dactylitis, nail, as well as axial symptom. The IL-17 is the cornerstone cytokine and play a critical role in the development of PSA, AS, and PSO. Now, there have been several biological therapies involving the treatment of PSA, We mentioned the TNF inhibitor, JAK inhibitors, IL-12/23, and the IL-17. And many therapeutic options are available that raise many questions. And as a physician, what helps us with regard to choosing the right therapy is knowing the domain, the shared patient-physician decision, and direct comparison studies, which include the head-to-head trials. Now, we have in practice two main IL-17 that we have been using, the ixekizumab and the secukinumab. In the SPIRIT head-to-head trial, they were looking at the composite, the ACR50 and the PASI 100. And the DMARD at that time, it was not allowed. And the study duration was at week 24. That was published in the Annals of the Rheumatic Disease 2020. While the EXCEED trial, the primary endpoint was achieving the ACR20, DMARDs were not allowed, and the week 52. The SPIRIT, it was an open label study, and it was randomized. While the EXCEED, it was a randomized trial, double-blinded. Now, we have two different studies. We're trying to answer the same question. So as a physician, what could help us, as we said, is the direct comparison. Now, in the ACR, we have a couple of abstracts that help us with regard to this answer as well. First of all, there was the safety and the tolerability of the ixekizumab versus adalimumab, a 52 weeks result from head-to-head comparison in patients with active psoriatic arthritis. It showed that the frequency and the type of adverse event was consistent with the previous trial. And the rate of discontinuation due to the adverse event was higher within the adalimumab versus the ixekizumab group, as well as the serious infection and the malignancy. Now, within the ixekizumab group, we had a higher rate of injection site reaction and inflammatory bowel disease. But the injection site reaction, it was localized and it was not associated with anaphylaxis. Then they extended the study in which the efficacy and the safety of the ixekizumab versus adalimumab in the SPIRIT head-to-head trial, a 52 weeks extension. So in the post hoc analysis with regard to the concomitant use on the methotrexate at week 52, the efficacy was similar across the multiple endpoint, regardless with the concomitant methotrexate use. So if you look at the composite endpoint, the ACR50 and the PASI 100, then the ACR50 alone and the PASI 100. But if you look at the bottom of the slide, the adalimumab had a lower response as a monotherapy, especially with regards to the PASI. Now let's go back to the secukinumab in active PSA patient, the ultimate trial, in which it was a phase 3 randomized double-blinded placebo-controlled trial in patients who are biological DMARD naive. And they were trying to confirm the joint synovitis improvement by ultrasound using the EULAR, the Umeric Global Synovitis Score, and the clinical enthesitis by the Spark Enthesitis Index. The primary endpoint was the mean change in the GLOS score, and it was statistically significant in the treatment arm, as well as the secondary endpoint, that is the ACR 2050, and the Spark Enthesitis Index was achieved, and it was statistically significant. Now, what about the axial PSA? Secukinumab have been shown to be helpful as well in axial PSA in the Maximus trial, in which it was a randomized double-blinded placebo-controlled trial that evaluated the efficacy both clinically and radiographically. Clinically, by looking at the ASAS-20 and the ASAS-40, that was statistically significant in the secukinumab group, shown in the dark blue, the 300 milligram, and the light blue, that is the 150 milligram. And in the bottom figure, we have the reduction in the Berlin MRI score, both on the spine on the left side, as well as for the sacroiliac joint at the right side. That was statistically significant, and it was sustained from week 12 to week 52. So what did we learn? That right now that the secukinumab have been involved in one more domain, which is the axial PSA. And the spirit head-to-head, there's right now with and without the DMARD, so you could use it without methotrexate. And it extended to week 52. Again, it's a physician decision, and it depends on the domain that is involved. I have to mention about one more drug, which is the guzilicumab in axial PSA, which is not new. It has been addressed right now for over a year, and even within the last ACR. And it showed that guzilicumab improved the clinical outcome in imaging confirmed sacroiliitis at week 52, the results from 2 phase 3 RCT trials. There was an improvement in week 24, maintained to week 52, and the efficacy was similar over HLA beta 27 versus HLA beta 27 negative patient. There was another abstract with regard to the same concern. It's an IL-23. They noticed that certain population there is increase in the acne, although it haven't been shown with regard to the IL-12/23 before. So I am interested to see further trials or to look more within the side effect, especially in the young population who have been treated with this in the future. What about patients' follow-up and monitoring in both axial SpA and PSA? We treated our patient, and we are interested to see what happened with regard to the treatment. So if there is any advantage of treat to target, tight control in axial SpA, we know that there's a TECORA in RA, and right now there's a TECOSPA trial in axial SpA, which evaluate the benefit of treat to target strategy, seeing the patient every month versus the usual care, seeing them every 3 to 4 months. This involved multi-center trial in Europe, about 18 centers that include France, Finland. We're not talking and even the Netherlands. We're not talking about regular center. These are highly specialized center who sees lots of SpA cases. And the results have been obtained in 1 year, in which the primary outcome is the ASAS high. Now, to let you know, the ASAS high, it consists of 17 components, which include the prom as well as the function. And they included all the showing secondary endpoints. And the results were the following. The treat to target group achieved 47% of the ASAS HI versus the usual care 36%, but it was not statistically significant. And we all know when the primary target, it's not reached, then you looked at the other either as nominal or not. The secondary endpoint, the rest of the ASAS have been achieved and it was statistically significant, but because the primary endpoint was not, so it's nominal. But it has been observed that the treat to target group, they were more efficacious and they had more biological use, of course, because they have been followed more frequently. And they were more cost effective and less medical report and the sick leave use. The safety profile were similar in both groups. So would you say that treat to target is better, but the usual care still did a good job? What about in psoriatic arthritis? The maintenance or achievement of minimal disease activity following treatment with adalimumab or methotrexate in patients with psoriatic arthritis. We know that there is no consequence about which is the best target to use in evaluation of patients with psoriatic arthritis, and NDA have been proposed to be one of them. Now, in this trial, in part 1, which have been published before, patients who have been in a PSA that receive MTX 15 milligram, they have been divided into 2 groups, the adalimumab plus the MTX and the escalating therapy in order to achieve the MDA, in which we know there are 7 components, and to achieve 5 of them, they're considered to be MDA. And as we can see on the right side, achievement of MDA at week 16 was statistically better in the adalimumab plus the MTX in comparison to the escalating MTX dose. So what about part 2? In the open label part 2, for those who achieved the MDA, In the adalimumab responders, 80% they achieve and maintain it over week 32 on the adalimumab monotherapy. And for those who achieve MDA in the escalating therapy, 67% responders maintain the MDA at week 32 with a continued methotrexate therapy. In contrast, for those who did not respond or did not achieve the MDA from the first place, which includes 30 to 55%. So what did we learn? A change in practice point. First of all, from part 1, achieving MDA from week 16 will lead to better in the combination group than the escalating therapy. And from part 2, patients who achieved MDA at week 16 maintain it until week 32 despite the removal of the methotrexate, i.e. the monotherapy, or you may consider it as tapering therapy. Now, whenever I see pregnancy abstract in the topic that I'm presenting, I always like to see what they're talking about. And I noticed about the pregnancy outcome in SPA, there are many abstracts. We don't know actually what's the influence of pregnancy on the SPA and the influence of the SPA on the pregnancy. There's no solid data. And there was a systematic literature review that includes case control, observation, and more than one studies with regard to the effect of the pregnancy outcome in the SPA therapy. And it was done in Dublin, Ireland. And the primary outcome was a maternal complication in which there was increase in the rate of cesarean section, preeclampsia, and the IUGR that was statistically significant. And with regard to the secondary outcome, the fetal complication, the prevalence of all the fetal complication was higher, but it was not significant. There was increase in the disease activity about 47.8%. So in conclusion, number of agents are available for the treatment of SPA with promising results, both clinically as well as radiographically. UBA have been observed in AS patients who are biological DMARD naive and the secukinumab in axial PSA. The PSA patient who achieved the minimum disease activity at week 16 generally maintain it until week 32 when removing the DMARD, specifically methotrexate, in the adalimumab responder group. Reassuring data for pregnant women in axial SPA and many more to come in the pipeline. Thank you so much for your attention.
Many thanks, Dr. Dan, for this very informative talk. Actually, we enjoyed it. So we'll take a question and answer until the end of this session. So it is my pleasure today to welcome my teacher and supervisor, Dr. Robert Inman. Proud to have my supervisor for about 3 years on board with us tonight. So actually, many of Saudi consultants have learned a lot from Professor Inman during their training at Toronto University. So Dr. Inman is a professor in Department of Medicine and Immunology at University of Toronto. He was Director of Rheumatology at University of Toronto and University of Health Network between 1991 and 2002. Prof. Inman has more than 350 publications and has manuscripts and chapters. He is currently the director of the Arthritis Center of Excellence at University Health Network, director of Spondylitis Program at Toronto Western Hospital, and deputy physician-in-chief at University Health Network. So Dr. Inman today will talk about two very interesting topics, starting his first talk about ACR update and psoriatic arthritis treatment guidelines. Then we'll talk about the updates and management in axial spondyloarthritis. So without any further delay, I will ask Dr. Inman to start his first talk. So please, Dr. Inman, thank you.
Good evening, it's Dr. Inman. I'm the senior scientist at the Shoulder Arthritis Institute in Toronto, and I have the pleasure of sharing with you an outstanding presentation that was conducted at the recent American College of Rheumatology annual meeting. I have been a consultant with AbbVie, Janssen, Lilly, Novartis, and Sandoz for disclosures. So Dr. Danielle Schwartz presented an outstanding presentation at ACR, and we thought that there was a very high caliber presentation that would be valuable to share with you. So the learning objectives of this psoriatic arthritis summary are to summarize the clinical features of psoriatic arthritis, to understand the clinical outcome measures we use in trials and clinical practice, and finally to grasp the therapeutic advances in PSA. So Danielle Schwartz is assistant clinical investigator at the NIH in Bethesda, Washington, DC. So this a couple of aspects of introduction. So psoriasis is a very heterogeneous disease, as you know. Largely, as clinicians, as rheumatologists, we would see predominantly plaque psoriasis. This typical plaque, this occurs in 85 to 90% of cases. It can also involve a guttate psoriasis, so deeply inverse psoriasis, pustular, which is commonly seen on palms and soles, and a very severe erythrodermic form of psoriasis, which can be quite overwhelming. But as rheumatologists, the bulk of what we would see would be typical plaque psoriasis with induration and a typical scaly superficial border. What is understood about the environmental risk factors? Well, certain infections, there's an interesting literature on streptococcal pharyngitis as a precursor for guttate psoriasis, even some studies on whether tonsillectomies can be preventative. Both HIV and antecedent infections on the skin are thought to be precipitant. Tobacco smoking as a factor in this equation, and a certain group of drugs, beta blockers, lithium, NSAIDs, antimalarials, and steroids can actually play a role too. Skin trauma Kepner phenomena, the local trauma on the skin can be certainly initiate a local flare. And UV light exposure might have a protective rather than an exacerbating effect. So there's an extensive literature on the environmental factors that can modulate the development of psoriasis. SAPHO is another important first cousin of psoriasis and psoriatic arthritis. This stands for synovitis, acne, pustulosis, hyperostosis, and osteitis. This overlaps with chronic recurrent multifocal osteomyelitis and can actually mimic the two, particularly when it's on the palms. But this very distinctive osteitis, particularly if it involves the sternoclavicular joint or the clavicle, often has quite a distinct appearance that may or may not mimic psoriatic arthritis. And then there are a variety of single genetic gene defect autoinflammatory diseases, deficiency of the IL-1 receptor antagonists, for example, Majeed syndrome, PAPA, are all can be associated with a combination of chronic skin lesions and progressive erosive arthritis. Just to keep in mind that pustular psoriasis can actually look a lot like these features. Psoriatic arthritis is highly prevalent in patients with psoriasis. This is a global map that shows the prevalence of PSA in the, patients with psoriasis. You can see that in some parts of the here North America, we would be in this range here, somewhere in the 20 to 25% range, with numbers in the US of 15 to 19%. Gulf states would be also in this range as well. So you can see that there is a geographical distribution, a clustering. Some countries here, for example, in Brazil, a very high rate of psoriatic arthritis in the psoriasis population. So this raises some interesting questions about both environmental factors, so for example, sunlight, but also genetic factors. And as with most rheumatic diseases, it's a complex interaction of environmental plus genetic elements. Typical forms of psoriatic arthritis are 90%. You do see distal involvement. The DIP involvement is quite characteristic of, obviously, often with coexisting adjacent nail dystrophy. An asymmetrical oligoarticular pattern can look rheumatoid-like sometimes, but sometimes the clue would be the asymmetry of the joint distribution. A polyarticular disease that can look very much like rheumatoid arthritis as well, for its the presence of symmetry and finger and small joint involvement, and axial involvement. So as we saw in a recent study, just summarized that in a recent Giselkumab study with psoriatic arthritis, approximately about 25% of patients at baseline had radiographic sacroiliitis. Sacroiliac involvement can be unilateral, and often the syndesmophytes can be radiographically somewhat different than would be seen in primary ankylosing spondylitis. Arthritis mutilans, which shows an osteolysis of the digits, very deforming and difficult to treat, is perhaps the most clinically challenging subset of psoriatic arthritis. Enthesitis is a very common feature of the insertion of the Achilles into the calcaneus here, and it occurs in anywhere from 30 to 50% of patients with PSA, and sometimes can actually be one of the most dominant clinical features of the disease, somewhat challenging to treat. And dactylitis, quite common again, with 40 to 50%, with a fusiform sausage-like digit appearance of the digits, not just involving just the joint itself, but in fact the whole digit, hence the sausage terminology in these patients. So enthesitis and dactylitis are certainly hallmarks of the disease. Nail dystrophy, very common, sometimes a real clue to the disease if the plaque psoriasis is not active, with both pits and grooves in the nail. And when looked for carefully, this can occur in 80 to 90% of patients with PSA, and it can also signal an adjacent joint which is destined for inflammatory involvement. X-ray changes can be really quite striking because of the fluffy periostitis we see here. It can be an intensely erosive arthritis, even more dramatic than rheumatoid arthritis, where you actually see dissolution of bone, the so-called pencil and a cup deformity here, and asymmetry in the sacroiliac joints, and these rather bulky, other than marginal or paramarginal syndesmophytes. So clearly a very destructive process that actually can coexist with an ankylosing. So here's one finger with the appearance of an ankylosed joint right adjacent to a very destructive erosive arthropathy. So sometimes the radiographic appearance is so distinctive that it's sufficient to make the diagnosis. So psoriatic arthritis tends to be more asymmetrical than symmetrical. Obviously, gout and OA is not less than chronic. These are usually not a significant differential, but sometimes osteoarthritis can be. PSA versus RA tends to be more oligoarticular, more distal, whereas rheumatoid arthritis would have more predilection for proximal joints, for example, like MCPs. All the digits of a joint, the same joint across digits would occur. Tender joints tend to be the higher scores than in RA, some discoloration. Spinal involvement, much more common in psoriatic arthritis than in rheumatoid arthritis. And sacroiliitis radiographically tends to be absent in rheumatoid arthritis. So these are what are called the Caspi criteria. So you need at least a score of 3 to get make a confident classification. You can see that with a history of present psoriasis at the present time, you actually see get a score of 2 here. Then this point scores falls off. So the negative test for rheumatoid factor, nail dystrophy, dactylitis, and characteristic radiographic features. So the Caspi criteria have been very useful in creating homogeneous patient populations. Of course, PSA exists as part of the spondyloarthritis family. From data we just summarized previously, you can see that ankylosing spondylitis versus psoriatic arthritis, the AS patients tend to be younger. There's a higher male to female ratio. On the other hand, there's higher peripheral joint involvement with PSA than there is in AS, and much more common dactylitis and enthesitis. And of course, psoriasis almost by definition makes a difference. 90% of patients with AS will be B27 positive, perhaps 40 to 50%, significantly lower. Important to keep in mind that psoriasis is a systemic disease. Besides the features we've just looked at, the nail dystrophy, the arthritis, the enthesitis, all these other features, non-alcoholic fatty liver disease, metabolic syndrome, chronic kidney disease, association with IBD, obesity, metabolic syndrome, all these comorbidities are also go hand in hand with in the psoriasis in the population. First, uveitis, there's a 2 to 5-fold increased risk for anterior uveitis associated with this, and in those in psoriasis, and it's even higher in patients with PSA. It can track with the B27 rate. Severe disease with PSA increases the risk. Generally, it's an anterior uveitis, but a posterior uveitis and conjunctivitis, scleritis, and keratoconjunctivitis sicca can be seen as well in the ocular disease associated with PSA. There is an association, the risk of 2 to 4-fold risk of IBD with psoriasis alone, cutaneous psoriasis. This is higher still with patients with PSA, a 6 to 10-fold increased risk. And it's more commonly Crohn's than ulcerative colitis. This bears on some important treatment decisions. We know now that, for example, etanercept and anti-IL-17 agents, both of which could be effective in psoriatic arthritis patients, are relatively ineffective in IBD. So this coexisting IBD in the PSA population might be an important determinant of selection of a biologic. There's a question of whether subclinical colitis actually exists in the PSA population. And of course, there's great interest among several groups looking at the role of the gut microbiome. Metabolic syndrome and cardiovascular disease, 2-fold increased risk of metabolic syndrome and 1.5-fold increased risk of a major cardiovascular event. Coexisting diabetes further increase that risk, as does non-alcoholic fatty liver disease. So coronary artery disease in this population, a very important comorbidity. Other extra-articular important considerations, 1.13-fold increased risk of chronic kidney disease. That would be independent of DMARDs and diabetes, because both diabetes and selected DMARDs can in and of themselves be associated with chronic CKD. Slightly increased malignancy risk, and particularly the lymphoproliferative diseases at a relative risk of 3.16, non-melanoma skin cancer at a relative risk of 7.5, and melanoma risk of 6.12. So important to keep, in terms of monitoring your PSA patients, very important to keep these comorbidities in mind: kidney disease, the cancer, the metabolic syndrome, etc. So treat to target, not just for RA. So this is an important concept, and defining exactly what the target should be is an active area of investigation across many groups. In general, disease activity in the prospective studies is measured over to 1 to 3 months, and if the target is reached, then you carry on. If it's not, you modify treatment. So the fundamental concept in treat to target is you have a well-defined endpoint, and if you're not meeting that endpoint, then it's time to change your treatment. Using in terms of the joints themselves, most commonly one of 2 outcome measures: the 28-point DAS 28, which would not include the feet, the ankles, or the toes, as used in some studies. In many longitudinal cohorts, it's preferred to use the 68 joint count, simply because ankles and toes and the midfoot are important joints in this disease. And some of that will be missed, as will the MCP joints and the 28 joint count. So the more comprehensive 68 joint count outcome measure, DAS-68, is as preferred by a number of PSA experts in the field. But you want to actually capture not only the joints, because as we said, it's a multimodal disease. So there are several aggregate outcome measures that seem to capture these other features. So for example, joints, disability, skin, dactylitis, and enthesitis, and the CPDI. The DAPSA includes the patient global joints and acute phase reactants. The PASDAS, the patient global skin, joints, enthesitis, dactylitis, and acute phase reactants. And minimal disease activity includes a patient global skin, disability, and enthesitis. So you can see that different groups have used different target outcome measures for treat to target. So that's important to keep in mind. But in general, the overriding concept is that it's not just about joints anymore. It's to include skin, global effects, for example, disability and patient global are very important and should be incorporated in when we're trying to decide. The fact that these seem to become comparable. So if you look at the DAS-28, CRP, SEDRAID, SDI, CPDI, DAPSA, PASDAS, this is either looking for definition of minimal disease activity or remission. The receiver operated curve you see is quite comparable. These two curves are not entirely super, they're quite close. So suggesting that the outcome measures here are actually quite comparable. Whether you use CPDI, DAPSA, PASDAS, there's a lot of commonality between the outcomes. So in terms of the outcome measure, this is an algorithm developed to look at how we actually work through a systematic approach, incorporating in our algorithm a treat to target approach. So active disease at the baseline, initiation of initial response, for example, DAPSA or MDA for PSA. We define either remission or low disease activity. And then once again, using DAPSA or MDA, we may decide that we want to press on to to achieve our targets. So this is actually an ongoing algorithm across the PSA trials about how you move through this sequence and how you incorporate all the different aspects of the disease in a comprehensive way. So to touch on just some of the studies, these are approved algorithms. Non-pharmacological treatment, very important. Smoking cessation, weight loss, exercise, very, very important, particularly in axial PSA, but also peripheral PSA. Exercise is not only important for general cardiovascular fitness, but has a tremendous impact on exercise capability, cardiovascular risk, and actually on mood. And depression is an important comorbidity in this disease. Symptomatic improvement. So we see non-steroidal anti-inflammatory drugs, short courses with corticosteroids, and of course, local glucocorticoid injections into the joints. Oral small molecules, methotrexate, sulfasalazine, cyclosporin, leflunomide, apremilast. 5 TNF inhibitors approved for use in psoriatic arthritis, 4 monoclonal antibodies and 1 receptor antagonist, 4 subcutaneous and 1 infusion, infliximab. 2 IL-23 blockers, ustekinumab, and 12-23 blockers is ustekinumab. Giselkumab is an IL-23 blocker. And the IL-17 blockers, secukinumab, ixekizumab, and brodalumab. CTLA-4 abatacept, and a JAK inhibitor, tafasitamab. You can see the dates of approval relatively recent. So we see that tafasitamab has just been approved by the FDA in 2017. So there's a broad range of approaches that requires a personalized, a customized approach to treatment, defining as precisely as possible what the outcome target should be. So just to highlight some of how we aggregate those responses. First off, the NSAIDs, we would say, for example, naproxen, diclofenac, indomethacin, a mild response in general in the joints. Virtually none on the skin, no significant response. If we look at classical DMARDs or oral small molecules, in terms of the joints, mild response with these classical DMARDs, and a moderate or mild response in the skin. So that is to say that methotrexate and leflunomide sulfasalazine can have a modest effect on joints and skin, but it would not be expected to be as dramatic as the biologics would be. If we look at the 5 TNF inhibitors I mentioned, a very good response rate for the joints and a moderate response in the skin. So mild response perhaps with etanercept. Often dermatologists tend to use a higher dose than rheumatologists would. Infliximab, excellent response, but you can see in general, the TNF inhibitors track record on joints is very good and reasonably good on skin. So that would be, but both have, before the advent of the new classes of biologics, the TNF inhibitors have had a profound effect on patients with psoriatic arthritis, both for skin and for joints. And then perhaps some dose optimization has to be done, more particularly when skin is the dominant element of the PSA patient. The newer additions to the pharmacological regimen, the IL-17 inhibitors, and this, the ixekizumab and secukinumab, very good response on skin. So that would be on joints, very good for both ixekizumab and secukinumab, and a wonderful response in skin, the cutaneous psoriasis, to the IL-17 blockers. And the IL-23 blocker, either 1223, ustekinumab, or the 23 blockers such as guselkumab, very, very good response to both skin and joints. Ranking the TNF inhibitors, we would say the TNF inhibitors show good, very good to very good response in skin and joints. The 1723 pathway is excellent in the skin and very good in the joints. So it's an interesting evolution of biologics, matching the biologic to the patient. The PDE4 apremilast shows a moderate response in joints and a mild response in skin. It actually is, amongst dermatologists, it still has an important place in the treatment of cutaneous psoriasis. But in general, it would have a lower, less robust response than, say, for example, a 1723 blocker would in this. But it certainly has, it's an oral agent with, you can see that it does have a place in the strategic plan. So the current approach sequentially is variable with the different groups, but many patients would start with the TNF inhibitors over an oral small molecule if the joints is, in some jurisdiction, starting methotrexate first or leflunomide before proceeding onto a biologic is sometimes mandated by third-party payers considerations. So that might mandate starting with an oral small molecule like leflunomide or methotrexate first. There are some, the other pathway of choice would be a 17/23, 12/23 blocker. This is largely because of the larger accumulated observation, but clearly with the expanded use of ustekinumab and now with guselkumab and et cetera in the blocking the 23 pathway, we will see variants on this. The important point about this slide is that regardless of whether the sequence is an oral small molecule or a biologic, and if so, whether it's a TNF or a 17, it's very important to assess, is the PSA still active? Because at that point, we should be adjusted, instead of carrying on with a disease with a treatment algorithm that is suboptimal, we should be prepared to switch to an alternative biologic to shoot for a low disease activity. So just a couple of comments then on the oral small molecules are classical, conventional small molecule DMARDs. Methotrexate, mostly for peripheral disease, not recommended as first-line agent. Leflunomide, modest ACR20 response rate, again, mainly for peripheral disease, but not a dramatic effect on skin. Sulfasalazine, less effect as well. Apremilast scored as a mild to moderate effect on joint disease, and usually often used in combination with other oral small molecules. And the importance of non-alcoholic fatty liver disease is illustrated here, only to keep in mind that if we are using here's the cirrhosis, but significant elevation in risk of cirrhosis, both with PSA alone and PSA in the presence of a DMARD. So keep in mind liver toxicity in this patient population. Treatment of refractory patients, as I mentioned, should not be sustained on inadequate control algorithms. Despite PSA is active despite a 17 or 23 blocker monotherapy, you can add in a methotrexate or consider switching to an alternative biologic. The important point here is to keep a close monitoring of the skin and joint disease activity before a significant damage actually accrues. Special cases, very severe psoriasis, so cutaneous psoriasis, very severe, consider go straight to the 23-17 blockers for the reasons we said. They're very dramatic on the skin. If there's poor compliance with injectables, again, a DMARD combination like a methotrexate combination might be useful. If IBD is coexisting with the psoriasis or psoriatic arthritis, we avoid etanercept and the IL-17 blockers. If the IL-23 TNF inhibitors failures, we would go right to ustekinumab, since it has demonstrable efficacy in IBD. Juzelkumab right here is an IL-23 blocker just approved in July 2023. It's an P19 IL-23, very highly effective. Here are the every 8 week, every 4 week versus placebo. This is the ACR20, ACR50 response, ACR70 response. And you can see these are very significant achievements. And if you look at the skin scores, the very significant, like total clearing is very significantly achieved with juzelkumab over placebo, very dramatic. During the COVID-19 epidemic, the current consensus from ACR and EULAR is that if a patient's autoimmune rheumatic disease is well controlled with a biologic or a DMARD, it ought to be interrupted. There's nothing to suggest that they worsen risk or outcomes in COVID, and we don't want to risk a flare of their arthritis during that period of time. So it's recommended that if they're not infected, carry on. If a patient on the biologics does in fact contract COVID-19 illness, hold the biologics until their recovery is complete. Telemedicine is coming. There's a lot of interest in monitoring skin and joint disease effectively by virtual care. I think we'll see a great deal more from both ACR and EULAR. So just to summarize, PSA is common and often under-recognized. Besides the arthritis, various patterns, there's dactylitis, enthesitis, and nail dystrophy. Associated comorbidities include uveitis, inflammatory bowel disease, metabolic syndrome, and cardiovascular disease. Advances in psoriatic arthritis include a treat-to-target ratio, and particularly the early use of TNF inhibitors, but also emerging drug classes such as 17 and 23 blockers and JAK inhibitors. Biologics are relatively safe to use during the COVID-19 pandemic, as telemedicine can be useful in the management of PSA. And with that, I will thank you for your attention. Goodbye. And the presentation at hand at the moment is updates from the ACR meeting in management of axial spondyloarthritis. And so I will provide some highlights from this year's meeting. In terms of disclosures, I've served as a consultant for AbbVie, Janssen, Lilly, Novartis, and Sandoz. Our teaching objectives for this session are really to understand the predictors of response to TNF inhibitors in patients with axial spondyloarthritis. Secondly, to recognize the efficacy of JAK inhibitors in these patients. Thirdly, to understand the differential IL-17 versus IL-23 blockade response in axial SpA versus psoriatic arthritis. And finally, to understand the extra-articular manifestations in axial SpA. So you can see that this year's ACR meeting was a very productive one for axial spondyloarthritis. So we'll take these themes one at a time. The first abstract I selected was entitled Biologic History and Sex Are Related to Golimumab Discontinuation. So the question arises in many of our patients with axial spondyloarthritis is, are they candidates for discontinuance if they've had very successful achievement of primary outcomes, usually at 24, 48 weeks. They're very stable. And the question sometimes arises then if they can be successfully discontinued at any point. So this was a follow-up study conducted on an earlier cohort, a post-registration of patients receiving golimumab for axial spondyloarthritis. And this basically captures the analytical approach to the question, which clinical variables are associated with successful discontinuance of golimumab. And you can see that age has been examined. Here are the hazard ratios, and here are the p-values here. You can see that a number of candidate variables, for example, age, disease duration, extraarticular features like GI, uveitis, were included, but the ones that really stood out were gender and a prior history of biologic agents. So the prior history of biologic agents, this has been an observation across all the biologic trials in axial spondyloarthritis, in that patients that have had inadequate response to a prior biologic, usually a prior TNF inhibitor, tend to be more a resistant subset than those patients who are TNF inhibitor naive, and that permeates most of the randomized controlled studies. So in a sense, you can see that the success rate for patients that have had prior being treated were discontinued at an earlier rate. And females, you can see here, are also discontinued at an earlier rate. So that does suggest that somehow gender does impact patients that will or will not be able to stay on their drugs for a prolonged period of time. So this is actually a large issue in the literature of axial spondyloarthritis. And this was another abstract that I selected that actually looks at baseline data. This happens to be from the ixekizumab axial spondyloarthritis cohort. But this data here actually is independent of treatment response. This data actually looked at the clinical variance between males and females with axial spondyloarthritis. And it provides an interesting snapshot. Again, these are baseline variables. So first off, women were older at disease onset than males with ankylosing spondylitis, axial SPA. You can see that the males was 30 years disease for females versus 26 for males. So that's one important variable to keep in mind. Secondly, women had a longer symptom duration than the males with axial spondyloarthritis. And this often goes hand in hand with a longer delay in diagnosis. So there's several variables that actually contribute to the delay in diagnosis in females, but as a result, there's a longer symptom duration in females than there are in males. Highest disease activity was seen in both groups, but interestingly, the fatigue, spinal pain, peripheral symptoms, and morning stiffness, 5 out of the 6 BASD questions were scored higher in women than in men. So that also tells you that the symptomatic burden of disease in females with AS is higher than the males with AS. That's the symptomatic burden of disease. In particular, more spinal pain at night, so what we would call nocturnal back pain, was higher in females than in males. Interestingly, the B27 prevalence was higher amongst men than women. Again, this achieves some statistical difference. There's no reason to think that why males, females would have the B27 difference, but it does come into the equation in terms of the diagnostic algorithm. And CRP levels tend to be higher in men than compared to women. So this is an interesting paradox because the symptomatic burden of the disease specifically most of the BASD questions will tend to be higher in females with AS than males with AS, and yet the CRP level is lower in females with AS than males AS. So you have actually two converging variables, one's symptoms, one's objective signs of inflammation. So it's an important factor to keep in mind in setting out treatment goals. It's also an important factor in predicting response to biologic agents. And gender always should be an important part of the calculation of prognostic features. The second prognostic feature that's been cited in the literature is actually their B27 status. This comes from Ato Diodar. This happens to be a study with secukinumab and axial spondyloarthritis. So they actually pooled several large studies addressing secukinumab, monoclonal antibody against IL-17A in axial spondyloarthritis, and generated the pooled analysis to see whether the B27 status of the patients affected outcomes. So you can see here that, in fact, as is the case, regardless of B27, patients receiving any dose of secukinumab, either 300 milligrams or 150 milligrams, were significantly more likely to report ASAS-40. Here's the ASAS-40 response, ASAS 5 out of 6, which includes a inflammatory marker, and here's the ASAS partial remission. So in each case, you see that regardless of B20, here's the B27 positive group, here's the B27 negative group. In both cases, there was a significant and enhanced response to secukinumab over the placebo, which is the dark gray here, regardless of a B27 status, using these ASAS-40 outcome measures. If you look at other outcome measures, which are consistently used in the axial SPA trials, you'll see a 50% improvement in BASD was achieved both to a greater extent in active drug, both 300 and 550 milligrams secukinumab over placebo in both B27 positive and negative patients. This is true for ASDAS CRP and ASDAS CRP less than 1.3 in active disease as the more rigorous treatment target outcomes. And once again, we don't see, we see a comparable a response in the B27 positive and negative ankylosing spondylitis group. This is actually in contradistinct to some other recent studies that had suggested that B27 negative patients may not respond as completely to biologics, but that was largely in TNF inhibitor trials. So in the IL-17 trials that we're looking at here with secukinumab, we don't see a B27 effect on the final outcomes. The other predictor sometimes is actually the objective signs of inflammation at baseline as a predictor of response. This is also ixekizumab, a monoclonal antibody against IL-17A. And the variables are, outcome variables are at ASAS-40, ASDAS less than 2.1, and a 50% improvement in the BASD. The variables here are placebo, a monthly ixekizumab, or every 2 weeks ixekizumab. So in the first panel, we see the grid here is a CRP and an MRI score. So if you look at ASAS-40 responses, you see that the asterisk here reflects a significant change. Patients that had both an elevated CRP but had a negative MRI score, less than 2, had a treatment response that was very significant for the acute 2 weeks. All the trends are here, regardless of baseline status, but you can see a bit of a trend here. So for example, if we look at ASDAS, 2.1 is the treatment outcome. Here are the patients with both the CRP elevated and the MRI positive greater than 2. The middle panel, normal, low CRP, but high MRI. And here is the group with high CRP, but a normal MRI. So you can see all three variables. In this middle, if ASDAS 2.1 is the outcome variable, you can actually see that patients that had the CRP in some outcome variables was a better predictor of the treatment effect size or the response than the MRI. So here we have a patient that, here the patients have an elevated CRP, but an MRI score less than 2. And that seems to be a pattern. So this is this comes in many jurisdictions. to start a biologic in axial spondyloarthritis requires not only a BASD of 4 at baseline, despite an adequate trial of at least 2 non-steroidal anti-inflammatory drugs, but it includes some objective sign of inflammation. And so that usually is an elevated CRP at baseline or a positive MRI, highly suggestive of active sacroiliitis. So you can see that both variables fit into the predictive model that they would have a response significantly higher. Once again, the patients that have both the elevated CRP and the positive MRI seem to have the greatest effect size, but it's an important thing to keep in mind. And there may be some differential prediction between the CRP and MRI. Certainly, ideally, across all these outcome variables, the patients that have both a CRP and a MRI positivity, as is evident in the ASTAS 2.1 achievement as a target, are the group that tend to be most responsive. So that's a useful, as with B27 and gender, baseline inflammatory markers figure in the equation of predictive response. The next study is a phase 3 tofacitinib study. This is rolling out a phase 3 JAK inhibitor study. The patients that had AS centrally read radiographs, modified New York criteria, standard. This is not non-radiograph. This is what we call radiographic axial spondyloarthritis, also known as ankylosing spondylitis. Once again, a BASD over 4, despite 2 NSAIDs, a 16-week double-blind placebo-controlled study to read either 5 milligrams BID of tofacitinib or placebo, and the primary response outcome is at week 16. If we look at the response outcomes, it's consistently favors active drug over placebo, as is evident the case. So once again, tofacitinib, 5 milligrams BID versus placebo, outcome measures at week 16, double-blind placebo-controlled trial. ASTAS 20 achieved in 75% versus 40%, very high effect size, perhaps a little bit higher than what we might expect to see with a TNF inhibitor, but a slightly higher placebo response. So the effect size would be comparable to most other trials we've seen. ASAS 40 being a more significant, a higher bar to meet for clinical outcomes. You can see, again, a very significant difference between active drug and placebo. ASTAS CRP, delta CRP alone, ASQ quality of life, SF36, BASMI linear, that's a spinal mobility measure, and the fatigue score. All of these consistently show a statistically very a higher response at week 16 after tofacitinib versus placebo. And these are type 1, so patient global, total back pain, BASFI, and questions 5, morning stiffness, question 5 and 6 on the BASD. Similarly, if you look at the magnitude of change, we see statistical significance very consistently with this oral JAK inhibitor. So to summarize, in the tofacitinib trial, 269 patients with ankylosing spondylitis were randomized to placebo or tofacitinib. Primary outcome measures at week 16, ASAS 20, significantly higher with the JAK inhibitor. Percentage of ASAS 40 responders, significantly greater with the JAK inhibitor, and significant improvements in ASTAS, CRP, AS quality of life, SF36, BASMI linear, and the fatigue scores. So that's consistent measurements. At week 16, we're seeing a very robust response to tofacitinib in comparison with a placebo. Secukinumab, in terms of persistent response, there were a few abstracts looking at long-term outcomes with the, and this is secukinumab, monoclonal antibody against IL-17A. And this is a 4-year follow-up study in which we see a very significant improvement in the outcome measures. So these would be, here's week 16 and week 256. So you can see that the trend here, the patients that respond to secukinumab 150 milligrams at week 16, or with nocturnal back pain or overall spinal pain, continue at week 260, so we're out to 5 years now, having these very significant improvements. This applies also to morning stiffness, question 5 and 6 on the BASD, SF36, BASFI, achievements that measurements that have been achieved at week 16 are persisting out at week at 250 to 60. Fatigue scores similarly improving, and ASTAS CRP. This is very reassuring data in terms of the persistence of a response with an IL-17 inhibitor, in this case, secukinumab. Once again, this is the minimal clinically important difference in outcome measures. So once we are seeing in the same domains for pain, nocturnal back pain, total pain, the average BASD score, SF36 BASFI for functional outcomes, fatigue, and ASTAS measurements anchored in CRP. So a high proportion of the patients that met the week 16 clinically important difference were actually sustained at 5 years. Once again, this speaks to the sustained effect of the IL-17 inhibitor, secukinumab. Very reassuring in terms of outcomes. These are week 16 and week 260 comparisons. Nocturnal back pain, responders at week 16, secukinumab versus placebo, and week 260. Of course, the placebos dropped off after the short RCT at the beginning. This is TNF inhibitor, previous TNF inhibitor inadequate responders. So once again, we see both in TNF inhibitor naive and TNF inhibitor inadequate responders, a very robust response at week 16 that is sustained at week 260, which is very reassuring. Another abstract of interest presented by Philip Meese, abstract 2025, is the effect of giselkumab, a monoclonal antibody that binds the P19 subunit of IL-23, on axial-related endpoints in patients with active psoriatic arthritis with confirmed sacroiliitis. So once again, this is taking a look at the giselkumab trial of psoriatic arthritis, PSA. It's focusing on those patients that have imaging-confirmed sacroiliitis to see whether, in fact, that subset of patients, PSA patients with axial involvement, have a detectable response to giselkumab, an IL-23 monoclonal antibody. So here's the response at week 24. This is looking at different proportions as ASTAS 20. We have here improvements in the ASTAS, and the patients achieving ASTAS inactive disease. So what you see at week 24, so here are the 2 doses of giselkumab, 100 milligrams every 4 weeks, 100 milligrams every 8 weeks versus placebo. You can see here that if in this response, the ASTAS response here is higher than in the 2 giselkumab arms than placebo. Similarly, if you look at a major improvement in ASTAS, significantly higher response with giselkumab than placebo at week 24. And once again, similarly with patients achieving inactive disease. At week 52, you do not see the sustained effect, but you have the crossover there. Of course, we don't have the placebo response at week 52 because the placebos have crossed over by that point. So the crossover from placebo to giselkumab at week 52 looks very comparable. So what is a particular note here is that using axial SPA sensitive patient outcome criteria in the patients with radiographic sacroiliitis seems to have a detectable response to an IL-23 blocker at week 24. So this is actually parallel data that was actually also presented at EULAR. So this provides a little bit more background information. There are two arms, 2 studies, Discover 1 and 2, looking at psoriatic arthritis response to giselkumab, an IL-23 monoclonal antibody. Once again, patients were extracted on the basis of baseline AP pelvis X-rays, and those that met the new modified New York criteria, that would be either a bilateral grade 2 or unilateral grade 3, were extracted from that cohort, and the normal axial SPA outcome symptomatic measures were applied to that group. So the ones we just talked about, BASD, modified BASD, spinal pain. And so just to recap what we just looked at, this is another way of demonstrating the data. You can see that at this initial assessment, here are the 2 doses of the juzelkumab compared to placebo. And we can see that overall 28% of the PSA population, by the way, had met the entry criteria for axial involvement. So 28% of the PSA patients recruited to the PSA trial had radiographic sacroiliitis. And within that cohort, there was a better BASD response, spinal pain response, modified BASD, SDAS-CRP in the juzelkumab arms than there was in the placebo arm. So this is also true when you look at BASD response, different outcomes, ASDAS responder. So these are endpoints in patients with radiographic sacroiliitis. So once again, the trend here is towards the psoriatic arthritis patients with axial involvement seem to have a very satisfactory response to the IL-23 blocker using axial SPA symptomatic outcomes. Now, why is this of interest and somewhat surprising? Because you might be aware that there's been several trials. This happens to be the risankizumab study that looked at an IL-23 inhibitor for ankylosing spondylitis. This was published last year. And you can see that with 2 doses, three doses of risankizumab, anti-IL-23 monoclonal antibody, there was no difference for placebo, whether we're looking at ASAS-40, ASAS-20, ASAS 5 out of 6, or achieving partial remission. Regardless of which axial SPA outcome measure which we use, in this study, an anti-IL-23 monoclonal showed no effect in ankylosing spondylitis. That's creating the interesting paradox that we have to resolve at the moment. So in the risankizumab study at week 12, ASAS-40 response rates were not significantly different over the placebo arm. The conclusion in that study was that the treatment with risankizumab did not meet the primary study outpoint and showed no evidence of clinically meaningful improvement compared with placebo in active AS, suggesting that IL-23 may not be a relevant driver of disease pathogenesis. So we have a paradox at the moment, that in the PSA trial, patients that had what seemed to be axial involvement were responsive. The patients that had primary AS, not psoriatic spondylitis, did not have a response. So it's a paradox. So that raises a question about whether primary ankylosing spondylitis is a different disease entity than patients that have psoriatic arthritis with axial involvement, aka psoriatic spondylitis. This is a study that we did at Toronto Western Hospital with Joy Feld, Vinod Chandran, Nigel Haroon, and Daphne Gladman to ask this question. And what we found was actually there are many variables that suggest PSA patients with axial involvement are different than primary ankylosing spondylitis. So if you look at these variables, there are a number of variables that actually look quite different. We also looked to see whether ankylosing spondylitis with psoriasis was different than axial PSA. And some of these variables, for example, B27, very significantly different. Peripheral arthritis, very significantly different. BASMI, the degree of patients with more advanced radiographic sacroiliitis, very significantly different in AS patients, and the duration of follow-up. So this actually suggests that when you look at these variables, active arthritis, the B27 status, duration of follow-up, that it suggests that they are really rather somewhat different. Ankylosing spondylitis and axial PSA have some overlapping features. They both score relatively high on a BASD, for example. They have morning stiffness and back pain, but the genetic, the clinical, and the radiographic characteristics are quite different. B27 occurs less in axial PSA than it does in ankylosing spondylitis. Axial PSA develops at an older age, is less symptomatic, and is associated with distinct radiographic features, and certainly milder degrees of radiographic sacroiliitis. Most comparisons in the past have had a cross-sectional analysis capturing different patients at different style in different points in the disease. In our study where we compared the two cohorts, they'd both been part of a longitudinal observational cohort. So it's an interesting conundrum, because the conventional wisdom is if a patient responds to an IL-17 blocker, which is true for both AS and PSA, then since IL-23 is upstream of that signaling cascade that eventuates in IL-17 production, then you would expect a patient responding to an IL-17 blocker should also respond to an IL-23 blocker, and that was actually not the case. This is a short report that Eric Gracie and Derek Elowak in Ghent have just published in collaboration with other group, only to say that when we think about IBD, ankylosing spondylitis, psoriasis, and psoriatic arthritis, there are important overlaps. Genetically, there are significant overlaps. For example, we see that all four of these entities are associated with polymorphisms in the IL-23 receptor in TYK2, IL-12B, but then there are distinct features. So for example, B27 is confined to the spondylitis group. The autophagy genes, ATG16L1, are confined just to the IBD group. HLA-C as a risk mark is just as a marker in this group, and HLA-B38 for psoriatic arthritis. So there are overlapping features, but there are distinct features, which is to say that when we look at different target organs, the skin, the joint, the axial spine, the enthesis, or the gut, we actually see a different pattern. So while this whole range of 5 target organs is responsive, for example, to TNF inhibitors, we see that axial spondyloarthritis is actually not responsive to an IL-23 inhibitor. And that's actually the mirror image of Crohn's disease and ulcerative colitis, because Crohn's disease does not respond to the IL-17 inhibitor, but does respond to an IL-23 inhibitor. So this is an important reminder as we go forth into the next generation of biologics that customized or personalized medicine is very important, because we have to actually combine a targeted approach to which target organs we're seeking and what's the response profile in each one of those target organs. So just to summarize, peripheral PSA responds to both 17 and 23. Ankylosing spondylitis responds just to the 17 inhibitor, but not the 23 inhibitor. And the question mark here is psoriatic axial PSA. It might be actually somewhere in between. More to come on this. Just to conclude, a couple of comments then on extra-articular manifestations. This study comes from our center, Gillian Fitzgerald, who is now back in Galway in Ireland, presented this paper at ACR. In this, we looked at our AS database in Toronto, 1,100 axial SPA patients, 66% males, average age of 40. 22% had a baseline had acute anterior uveitis, 5% had IBD, and 4% had psoriasis. In terms of other important comorbidities, at study entry, you can see that hypertension, peptic ulcer disease, depression, hyperlipidemia, asthma, kidney stones ranked in the top group of comorbidities over time. And so what Gillian is currently involved with is to actually look at the accrual of extra-articular features over time. So we can see that at baseline, those figures, you have 22% uveitis, 5% IBD, 4% psoriasis. You can see that over time, as we follow studies, so the patients have been followed up to 15 years in the clinic, we see the addition of uveitis, the incidence rises over time. The incidence rises also in psoriasis and in IBD, albeit at a lower accrual rate than in psoriasis or uveitis. So important question, because if we are interested in asking whether we can intercept the development of some of these extra-articular manifestations with timely biologic interventions, we need to know what the normal trajectory of EAMs is. So this will be important. Finally, risk factors of outcomes. So it's presented from 2 European multidisciplinary clinics. Ana Cruz Machado presented this at ACR. This was a group of 45 psoriatic arthritis patients, 23 axial SPA, 18 undifferentiated. And adverse pregnancy outcomes, APO, occurred in 41%, which included early miscarriages, preterm births, fetal growth and patient-reported size. Again, patients with adverse pregnancy outcomes, without pregnancy outcomes, there were a few predictors. Here, the history of IBS, DMARD use, and active disease before conception. So this is a question that commonly arises amongst our patients with ankylosing spondylitis and childbearing age. So overall, TNF inhibitor responses in axial spondyloarthritis is sensitive to baseline inflammation, whether it's measured by CRP or MRI, and it's sensitive to gender because we see different response rates in the males and females, but not B27. B27 seems not to be a predictor of TNF-I responses. The JAK inhibitors, as illustrated here by the tofacitinib data, appear to be very effective in this early RCT at 16 weeks over placebo. There are differential responses to IL-17 inhibition versus IL-23 inhibition in axial spondyloarthritis versus psoriatic arthritis with axial involvement. And obviously there's more to come on that because as we understand the biology better, that'll fall into place. Overall, comorbidities and extra-articular manifestations accrue over time. And if we can interrupt or intercept the development of those EAMs with timely biologic intervention, that would be valuable indeed. Thank you very much.
Thank you very much, Prof. Inman, for this very informative updates on spondyloarthritis and psoriatic arthritis. Actually, we have a few questions. First question for Prof. Suzanne. The question saying, was the flare of axial spondyloarthritis during the pregnancy secondary to mechanical back pain or inflammation?
Oh, a good question. So the effect of pregnancy on spondylitis is an important one. We've done a study in Toronto looking at this question. We found that in the first trimester, back pain actually improved as it does in rheumatoid arthritis, but then in the second and third trimester, the back pain worsened. Now, is that worsening with pregnancy a mechanical factor, or is it hormonal and immunological? We really can't say. I think what we can say is there's certainly an important component of mechanical stress on the sacroiliac joint. So, for example, if you do an MRI at 3 months and 6 months postpartum after labor and delivery, you see a tremendous amount of bone marrow edema, even in patients that don't have spondylitis. So these are normal women going through labor and delivery. They end up with a very significantly positive MRI for bone marrow edema. So I think what we can say is that pregnancy and labor and delivery does introduce an important biomechanical stress on the SI joint and the low back pain. I think what was reassuring about our data is that we found if you follow up the patient 6 months after pregnancy, they didn't have worse AS. So our conclusion in our study was that the pregnancy does not seem to accelerate the severity or the course of ankylosing spondylitis. The patients will indeed experience a lot of back pain during pregnancy, probably more biomechanical than immunological, but on the reassuring side, it didn't seem to worsen the long-term outcome for AS.
Prof. Suzanne, do you have any comment on that question?
Yeah, of course, I will echo Prof. Inman's point, and it's always have been a challenge. Despite that, the abstract that I presented showed about 40% or 47% of the patient, they do flare during pregnancy. But the challenge is, how are you going to differentiate whether it was a mechanical back pain related to the pregnancy itself versus an inflammatory? Remember, you cannot do an MRI at that point. Even the post-delivery MRI is going to show an acute phase of inflammation, which is transient at that time. So I totally agree. But the good news is that according to the data that I presented, that neither the mom nor the fetus, they do have a complication in pregnancy.
Right. I agree. That's very good. I agree 100%. It's
Thank
very
you.
reassuring because many of our women with back pain are very, very worried about the effect of pregnancy. So I think it's important that we can reassure them.
Okay. Now, what I noticed over the past couple of years, and it was mainly last year and even this year, there have been many abstracts with regard to pregnancy and rheumatological disorder. People start to do more right now. People start to observe. People start to want to know the real world experience, i.e., because this is the childbearing age group that we're focusing right now.
Right. Right. So, I mean, I think that's very important. Because almost all our rheumatic diseases are clustered in these childbearing years, the 20s and 30s. I think our approach generally has been, if a patient's well controlled on a biologic, we carry on the biologic right through the pregnancy. That's our gastroenterology GI colleagues do the same thing with Crohn's disease. The one exception is, of course, NSAID. So if patients on an NSAID, we stop it at the end of the second trimester, week 26. But otherwise, the biologic safety during pregnancy looks good enough that we carry on right through the pregnancy.
Absolutely.
Thank you very much. So the second question, maybe for Dr. Inman, is there any explanation for gender variation in regards to anti-TNF response? So the other question is why female lucky than males?
So this is a complicated issue. So the question is, why did the TNF inhibitor response is better in males than females? So there are a couple of possibilities. One is that there's more diagnostic uncertainty in the females than males sometimes. So sometimes it's compounded by coexisting fibromyalgia or degenerative disc disease. Maybe that's a more likely comorbidity in the females than the males. The second possibility is that there's something biologically quite different. And I mention that because although the BASD scores tend to be higher in females than males, the CRP tends to be lower. So remember, as you start a group of males and a group of males with AS versus females with AS on a biologic, then the baseline CRPs will be lower in the females. Now, baseline CRP tends to be a moderate predictor of TNF responsiveness, so that's important. Secondly, we also recognize that non-radiographic axial SpA has an important gender bias, right? There are more women represented in non-radiographic axial SpA. So that also suggests there's something biologically different about the diseases in the two genders, because in the males, you're more likely to have radiographic sacroiliitis with erosion, sclerosis, and ankylosis, whereas in the females, they're more likely to be non-diagnostic. So I think that it's a combination of the outcome measures we use, like we use a BASD or an ASTAS-20 as one of the anchor outcome measures, and that's influenced by gender. Both pain scores and CRP are influenced by gender. So I think it's true. I think the bottom line, of course, is that we would never, regardless of whether it's a male or a female, if they are symptomatic, we're confident of the diagnosis, they've failed 2 NSAIDs, we will always proceed with the biologic, of course. We might have slightly lower expectations of a response in the females, but we would still, of course, treat both.
And with regard to the gender variation, there's a very interesting abstract that presented that show female tend to have more skin lesions with regard to the psoriasis than the males. Now, is that going to lead or make us to change our management plan based on the gender difference? We don't know. I think that this is something that we're looking forward for the new GRABA guidelines, because in those guidelines we say that we're going to look more into comorbid illnesses, and it will give us more answer and more details.
Definitely, I agree with you 100%, because I think that if that's true, that would lead us more to IL-17, IL-23s than a TNF, for example.
Thank you very much. So I have here a good question about that. We have new data coming for tofacitinib and for secukinumab. We know that the guideline recommendation usually coming behind because they are not very updated comparing with the data. So the question actually for both, how can we consider tofacitinib and secukinumab? Can we consider them as a first line if we want to? Like, for example, if we have a patient with rheumatic arthritis with significant psoriasis, or I have AS patient with psoriasis, for example. Can I start secukinumab instead of anti-TNF?
Yes, I think it depends on the jurisdiction. I think that generally, of course, in the and you're absolutely, I agree with Dr. Badawi that the recommendations, both the ACR or the ULAR ASAS recommendations, are always a bit behind. It takes a while to update the recommendations. So, for example, on the last ACR recommendations, they preferred starting with the TNF inhibitor before an IL-17, but that was largely not because there was a difference in efficacy. It was just we've got much longer observation period for safety with the TNF inhibitors. Now, that's changing. We have a much better observation period for secukinumab and ixekizumab than we did previously, and that will apply to the IL-23 blockers and TOFA as well. So, and TOFA, of course, TOFA is not yet approved for axial SpA, but it's going to be close. There's a big, the phase 3 study should be published in the coming months. It looks very convincing. So I think that at the moment, it partly depends on the local jurisdiction. We have the strength of the TNF response data is that we've got almost 15 years of data. The IL-7, if the disease, however, is significantly cutaneous, whether this is PSA or dactylitis or nail dystrophy, if that is a significant burden of disease and it's as much axial as peripheral as axial, then there's a strong case to be made for starting with a 17 or a 23 blocker and TOFA. I think that it will take time to sort out. We have very, very few head-to-head comparisons, right? So we have one head-to-head comparison looking at ixekizumab versus adalimumab, and they look very comparable. So if you look in the axial SpA data as it currently exists, it looks like the IL-17 blockers look comparable to the 17 the TNF blockers. For axial SpA, but when you bring skin into the equation or peripheral joint, the balance tips more towards the 17-23 axis. So I think the recommendations are certainly going to be updated very shortly. Will we get to a point where we actually can start, say, a JAK inhibitor as a first line? I think it's possible. We're not there yet, but I think it's possible.
And again, when you look at the guidelines with regard to the treatment of AS, the first guidelines is the anti-TNF, and the second, as we said, it could be the IL-17, and the third, the JAK. Now, the thing is, as you pointed, how long the physician have been dealing with anti-TNF? How much experience do they have? Almost more than 15 years. They know how to deal with the side effect and to handle them. But with regard to the other agent, 5 years, and finally the JAK inhibitor, which are not approved just recently. And the data that we have for TOFA, it's only for 12 weeks yet. And at that point, there's no radiological, there's no comment, and they didn't do the radiological assessment. But on the other hand, the UBA, it have clinical as well as radiological component. So I think, as you said, it's going to be promising, but it depends how comfortable is the physician in handling something that have been in practice more than 15 years versus 5 years or 1 year. Thank you.
I agree.
So I have a very interesting question here about IL-23. So they're saying, is there any explanation why IL-23 is not working on axial is working on axial psoriatic arthritis and not on ankylosing spondylitis? So
so basically that's, I presented our data. It suggests if you look at psoriatic spondylitis, in other words, PSA with axial involvement, it really looks different than primary AS. First off, the degree of pain is less in the spine. The B27 rate is lower. The degree of radiographic change, like syndesmophyte formation, is different. So in many ways, the two diseases look quite distinct. Now, why one should respond to a 23 blocker and one doesn't, it's a puzzle. It really is a mystery. I mean, we did a study looking at mucosal associated invariant T cells. These are what called mate cells. And they actually produce IL-17, but not through a 23 pathway. So there are other cells that can actually produce IL-17 being triggered by cytokines other than 23. In other words, so we might have an explanation why both groups would respond to an IL-17 blocker, but only one responds to an IL-23 blocker. But I think the immunology is just now getting worked out. It's a bit of it was a bit of paradoxical. It was unexpected that there would be a divergence between the two. So I think we're still learning.
Sure. Thank you.
And even so, and they did comment on that on many of the abstract, despite that you know that certain agent, what exactly it block, but they don't know why it have a positive effect on the other component. Is it because of the multi-cytokine or else? Nobody knows.
Exactly. I agree.
Okay. So here we have a question. Do we stop IL-17 in pregnant lady with severe psoriatic arthritis?
Oh, I think we're okay. I mean, in terms of the safety profile. So we're still okay with carrying on the biologic during pregnancy. And again, the concern was you don't want a major flare during pregnancy or postpartum of IBD or spondylitis or psoriasis. So you don't want to be you don't want to impose a significant disease flare on the patient when they're caring for a newborn. So I think the rationale is to try to keep the patient under control right through the pregnancy as best you can.
Thank you, Dr. Ayman. So the other question saying, what is the best biologic agent to treat AS in patients with active cancer? That means maybe meaning recent cancer, as TNF is contraindicated. Is there any?
Well, I think this is early days. Back to Suzanne's comment, like we have the observation period is the longest for TNF inhibitors, then the 17s, shorter for IL-20, and shortest for the JAKs. So we do have data from the IL-17, the TNF literature. If a patient's had a prior cancer, and they go onto a TNF inhibitor, does not increase the risk of a second cancer, right? So there's most of that data is reassuring. And if you look at the data about secondary malignancy generally, not just lymphoma, the non-melanoma skin cancer and all solid tumors, rheumatoid arthritis and then PSA have a higher cancer prevalence than AS. AS of the three major inflammatory joint diseases has the lowest. And so it's very hard to tease out, of course, whether the biologic actually is playing a triggering role there. And remember, in the early days of rheumatoid arthritis TNFs, there was initial reports of a higher rate of lymphoma in rheumatoid arthritis patients treated with TNF inhibitors compared to the general population. That was true. The problem was that that's not the right comparison group. The comparison group is rheumatoid arthritis patients of comparable severity, not on a biologic. And when you look at that, there's no significant difference. So the feeling has been in RA that it's the burden of inflammatory disease that's driving it, not the biologic. And happily in AS, there's a much lower prevalence generally of malignancy. So we're always cautious. We mention it to the patients. And the newer agents we'll just have to see. When we accumulate more experience with the 17 and the JAKs, we'll have better data.
So can we consider IL-17 as a first line, just avoiding anti-TNF in the case of recent cancer?
I think it would be defensible. If we face that situation, I think we would insist that there be that's a joint decision between the oncologist and the rheumatologist, right? Because we often have to coordinate it with the chemotherapy. If the patient's undergoing chemotherapy for the cancer, we often back off and wait until the oncologists have finished the chemotherapy cycle. Then we have a discussion about a biologic after that.
Okay, and I totally echo that point with regard to the cancer treatment, that we do treat the patient first and then we decide because they are because from the observation trials, we don't know why, but some of those patients, they do respond or their inflammatory component does go down.
Right.
Thank you both. So I have to close this session with only last question. What type of delivery do you prefer in an ankylosing spondylitis patient?
Sorry, can you say it again, Mohammed? What was the question?
What type of delivery do you prefer in AS patient?
Oh, for pregnancy?
Yeah.
That's complicated. I leave that. I'm not an obstetrician.
Yes.
So I would basically leave that. I would say that we have patients, even with fused SIJs, that have conventional natural vaginal deliveries. Like you would think that's the group that's going to go to cesarean section. But actually, we have patients that have successful natural deliveries without C-section. So I pretty much leave that up to the obstetrician and the patients.
Totally agree. I do leave this option to the obstetrician, and as we saw from the data, that the majority of the patient, they undergo cesarean section. And when talking some of the experts, let's say the high-risk pregnancy obstetrician, I did ask them this question regarding such patient, and they do prefer to go even electively for cesarean section in order to avoid any emergency cesarean section at that point.
Right.
Thank you.
Thank you very much. I think that was the last question. Thanks, Professor Inman, for being with us today. Actually, it was our pleasure and hoping to see you soon and other activities. So thank you, Professor Suzanne, and I think you are staying with us. See you, inshallah. Thank you, Professor Inman. See you. Take care. Bye. So I think this is the end of this session. I give back the mic for our chair, Dr. Fahd Al-Anizi, and thank you again for joining us. So I will close this session. I'm preparing for the next vasculitis. Thank you very much.
Thank you so much, Dr. Mohammed Abdawi, and thanks a lot for all the speakers and the chairperson for the informative, valid presentations. So I'd like to welcome you again, and I wish we are enjoying tonight with the valid and scientific presentations. So it's my honor and it's my pleasure to introduce for you the chairperson for the next sessions. He is Dr. Abdullah Al-Mutlaq. Dr. Al-Mutlaq, he is a rheumatology consultant at King Faisal Specialist Hospital and Research Center in Riyadh. Dr. Abdullah, he has a post certified at the Saudi Fellowship in Rheumatology in 2014. Also, he had clinical research fellowship in vasculitis at University of Toronto. With no further delay, I would like to welcome you again, Dr. Al-Mutlaq, and the mic is yours.
Thank you very much, Dr. Fahd. It's a pleasure to be here, and thank you very much all. I would like to welcome you all to this evening session with our speaker, Dr. Carol Langford. It's really a pleasure to be introducing Dr. Carol Langford, who received her medical degree at UCLA in 1987, followed and trained in the internal medicine at University of Michigan. And then she was a fellow of rheumatology at Duke University until 1994, where she also received a master's in health science. Later on, Dr. Langford was a senior investigator at the National Institute of Health, focusing on vasculitis from 1994 to 2004. Afterwards, she joins Cleveland Clinic and became the director for the Center of Vasculitis Care and Research. She is also an associated professor of medicine at the Cleveland Clinic Lerner College of Medicine. And in 2007, she became the vice chair of rheumatology for research at the clinic. It's really a pleasure to be introducing you, Dr. Langford. Thank you so much for being with us. Without further ado, please, Dr. Langford, the floor is yours.
Hello, I'm Carol Langford from the Cleveland Clinic. I want to thank the organizers for inviting me here today. Today, we're going to be discussing updates in managing non-ANCA associated vasculitis. My disclosures can be seen on this slide. In today's discussion, we're going to be reviewing information presented at the ACR Convergence 2020 meeting related to giant cell arteritis, Behçet's disease, CNS vasculitis, and I'll also be reviewing with you my thoughts about the best vasculitis abstract presenting during the Convergence meeting. So starting with giant cell arteritis, this is a granulomatous large vessel vasculitis that affects people over the age of 50. It can be recognized by its four phenotypes, which include cranial disease with the potential for permanent blindness, polymyalgia rheumatica, systemic inflammation, and large vessel disease, which can occur in up to 1/3 of patients, including the risk of thoracic aortic aneurysms. Now, the treatment options that were available to us prior to 2017 included glucocorticoids, which have been shown to reduce symptoms and prevent vision loss. But the problem is that this does not prevent the occurrence of relapse. Many patients need not long-term use, and this is associated with substantial toxicity and risk of morbidity. Methotrexate has been examined in 2 randomized trials and a meta-analysis, which have demonstrated at best a modest benefit in the treatment of giant cell arteritis. Most recently, we have had data regarding the use of the IL-6 receptor inhibitor tocilizumab. This was the focus of a randomized trial in which patients were randomized to one of 4 arms, either a prednisone 52-week schedule, a 6-week schedule, or 2 tocilizumab arms, either 162 milligrams once a week or every other week, both of which were combined with prednisone, which was tapered over a 26-week schedule. The initial prednisone dose ranged between 20 to 60 milligrams a day as chosen by the investigator, and prednisone doses were double-blinded when they were less than 20 milligrams a day. Sustained remission was defined as no flare after week 12 and completion of the prednisone taper, with the primary endpoint being sustained remission at week 52, comparing both of the tocilizumab arms to the prednisone 26-week tapering schedule, with the secondary endpoint being sustained remission of both prednisone arms compared to the 52-week prednisone schedule. We can see in these results that there were similar rates of sustained remission in the prednisone arm. Both tocilizumab arms were superior to prednisone at either 26 or 52 weeks. However, the rate of sustained remission on both of the tocilizumab groups remained less than 60%. Tocilizumab was associated with a lower cumulative prednisone exposure, and the adverse events were balanced across groups, including no bowel perforations. Additional analyses from this trial yielded some important findings. Most flares occurred while patients were still on prednisone, which included 64% of flares in those in the tocilizumab arm and 76% of flares in those who were on the prednisone alone arms. Importantly, was that 25% of flares in the tocilizumab group occurred at doses of greater than 10 milligrams of prednisone a day. We initially saw that the acute phase reactants were of limited value in monitoring giant cell arteritis. Based upon the IL-6 inhibition affecting CRP, not surprisingly, was that in the tocilizumab treated patients, CRP and sedimentation rate did not rise with flares. However, in the prednisone alone groups, CRP and sedimentation rate remained normal in 1/3 of flares, and over 50% of patients had a rise in CRP or sedimentation rate without evidence of clinical disease flare. In addition, tocilizumab appeared to act rapidly, with a higher proportion of tocilizumab-treated patients achieving remission by week 12. So this experience raised some important questions about what happens after tocilizumab is stopped. Can we minimize or avoid prednisone use with tocilizumab? Are there other means of assessing disease activity in giant cell arteritis? And other treatment options, given the fact that sustained remission continued to occur in fewer patients than we would desire. So in terms of what happens after tocilizumab is stopped, this was an important aspect of the GIACTA trial, which was presented at the ACR Convergence meeting. In this trial, following the 52-week primary endpoint assessment, there was a second part following patients after blinded treatment injections were stopped, whereby they were followed for an additional 104 weeks. This abstract provided the results examining the Part 2 course of the 81 patients in the tocilizumab arms who were in sustained remission at week 52 and stopped treatment. So this was a very clinically relevant population in helping us to understand what happens after treatment is stopped. In all 81 patients, 46% experienced at least one flare at a median time of 24 months. The relapse features continued to consist of cranial and PMR features, which differed slightly depending upon whether patients were enrolled at the time of a new diagnosis or at the time of relapse. Visual features occurred in 3 patients at the time of flare, but no episodes of blindness occurred. So over half of patients who were in sustained remission relapsed when tocilizumab was stopped in this trial after 1 year. So what about the question about the use of glucocorticoids and whether this could be minimized? This was the focus of an abstract presented at the ACR Convergent by Kristen and colleagues, which examined a proof of concept study examining ultra-short glucocorticoid administration. In this open label study of 18 patients with newly diagnosed giant cell arteritis, patients were treated with IV methylprednisolone 500 milligrams a day for 3 days with no further glucocorticoids, together with tocilizumab, 8 milligrams per kilogram IV for a single dose, which was followed by 162 milligrams a week subcutaneously, day 10 through week 52. The pre-established primary endpoint was observing 40% or more of patients of the first 12 would have either have remission within the first 31 days without relapse at week 24. With their interim analysis of the first 12 patients at week 24, we can see that this did not achieve the primary endpoint, in that 25% achieved remission at 31 days and stayed relapse-free by week 24. In the overall analysis of the 18 enrolled patients, we do see, however, that 14 achieved remission at a mean time of 11 weeks, 13 of whom maintained this remission within 24 weeks. And if we look at the graph demonstrated on the slide, we can see that while patients did achieve remission, it appeared to take a longer period of time to do so. Importantly was that 3 patients were non-responders, including 1 that experienced visual loss and 2 discontinued treatment due to adverse events. So while the study does not support the use of an ultra-short glucocorticoid dose, the fact that patients were able to achieve and sustain remission does raise the potential for further investigation of alternative glucocorticoid regimens in combination with tocilizumab. In terms of assessment of disease activity, this has remained a challenge and was the focus of a number of abstracts during the ACR Convergence meeting. In conjunction with the GIACTA trial investigating tocilizumab, samples were obtained for evaluation by mass spectrometry with the purpose of trying to identify novel biomarkers to assess disease activity. Samples were analyzed in 21 patients that received prednisone and 21 patients in the tocilizumab arm at distinct periods of time where they had active and inactive disease. We can see on the slide the top 10 markers that were found to distinguish active as compared to inactive disease. And in the tocilizumab arm, one of those included haptoglobin, which is an assay that can be readily established. They then examined these top 10 biomarkers and drew up a ROC curve of these in terms of differentiating active and inactive disease. And we can see that the average area under the curve in the tocilizumab group here was 0.97, being very close to 1, therefore demonstrating a good role in differentiating active and inactive disease. So while very preliminary and not yet applicable to clinical practice, this work supports the potential for ongoing research to identify serum biomarkers in giant cell arteritis. Now, another means of assessing disease activity, which has been the focus of investigation, has been through imaging methods. And this was the focus of an abstract by Quinn and colleagues at the National Institutes of Health that examined the feasibility of fluorodeoxyglucose positron emission tomography, or PET scanning, to monitor the effect of tocilizumab in giant cell arteritis. In these 25 patients treated with tocilizumab over 2 years, PET was performed at baseline active disease and during follow-up visits. A PET-VAS score was calculated, which examined the FDG uptake in 9 arterial territories as assessed by a blinded radiologist, and linear regression was performed to examine the change in PET-VAS over time. We can see that a significant reduction in the PET-VAS score was seen over the 2 years, and that a decline in PET-VAS continued past year 1. However, PET features that are consistent with active disease remained in 44% of patients, and also in 6 patients who stopped tocilizumab due to disease remission, 5 were observed to have increased PET activity after 6 months, with 2 later having a clinical relapse. This work raises several interesting questions. Could PET provide a novel outcome measure in future clinical trials of giant cell arteritis? The fact that 44% continue to have persistent PET signal raises interesting questions about whether this represents active disease or other causes. And as PET continued to improve over time, it raises a question about whether tocilizumab duration should be extended in some patients, as has already been raised by the clinical trials. With what about regards to other therapies of investigation? And this was the focus of a late-breaking abstract presented by Sid and colleagues who investigated mavrilimumab in giant cell arteritis. The rationale for this trial was based upon the observation that Th1 and Th17 lymphocytes have both been to play a role in giant cell arteritis pathogenesis. GM-CSF is an upstream mediator of both Th1 and Th17 cells, and based upon the fact that mavrilimumab, an anti-GM-CSF receptor antibody, has this activity, this was the focus of the investigation in giant cell arteritis. In this trial, 70 patients were randomized at a 3:2 ratio to receive either mavrilimumab, 150 milligrams subcutaneously every 2 weeks, versus placebo over a 26-week prednisone taper. The primary endpoint was time to flare by week 26, and we can see at this time point that mavrilimumab had a lower time to flare as compared to those who received placebo. They also had longer sustained remission. Adverse events were similar between groups, and there were no deaths or episodes of vision loss. So in these results, mavrilimumab was superior to placebo in time to flare and sustained remission. Further safety and secondary endpoints are currently being analyzed, but this would appear to warrant further investigation in giant cell arteritis. Shifting then to Behçet's disease, this is a multi-system illness in which we can see prominent involvement with oral ulcers and ocular disease, as well as potentially life-threatening manifestations which can involve the central nervous system, gastrointestinal tract, or a range of vascular features. Most recently, a randomized trial has been conducted with apremilast, which is an oral small molecule phosphodiesterase 4 inhibitor. In this trial, patients were randomized to receive either apremilast 30 milligrams twice a day or placebo through week 12, following which time all patients received apremilast until week 64, at which time this was stopped and a 4-week observation period ensued. 207 patients were randomized. At the primary endpoint, which was the area under the curve for the number of oral ulcers, apremilast was superior to placebo. Apremilast was also associated with a reduction in oral ulcer pain, freedom from oral ulcers by week 12, and improvement in the Behçet's disease quality of life score. There was a similar rate of adverse events, which particularly included diarrhea, nausea, and headache. So apremilast was found to be effective for the treatment of oral ulcers related to Behçet's disease. Now, as mentioned, Behçet's disease is very much a multi-system illness, and for that reason, questions have been raised as to whether apremilast may have any utility in the other disease manifestations. This was the focus of an abstract presented at the ACR Convergence meeting, in which, during the trial of the apremilast, there was examination of the non-oral ulcer manifestations during the course of the trial. In this study, patients could have prior multi-system disease feature, but of note was that active major organ disease was prohibited at the time of enrollment, such that these patients were excluded. During the course of the trial, they were evaluated for the development of new, recurrent, or worsening of non-oral ulcer features, and specific data was obtained for the physician global assessment of skin lesions, as well as swollen or tender joint counts. We can see in these graphs, they're tracking for one or more of the presence of new, recurrent, or worsening of overall non-oral ulcer Behçet's manifestations, as well as skin lesions and arthritis. And we can see that in each of these instances, placebo was associated with a higher rate of development of these features. So apremilast was associated with lower rates of new, recurrent, or worsening non-oral ulcer features. However, as active major organ disease was excluded from this trial, we must be cautious, and the efficacy of apremilast is unknown for these features at this time. Shifting now to primary central nervous system vasculitis, this is an uncommon but serious form of vasculitis in which the clinical features can include pervasive headache, focal neurological manifestations such as stroke or neurological deficits, visual symptoms, or altered cognition. Abnormal imaging and analysis of cerebrospinal fluid play critical roles in the assessment and diagnosis of CNS vasculitis. Brain biopsy can demonstrate granulomatous inflammation, lymphocytic infiltrates, or necrotizing vasculitis. Challenging the diagnostic process is that there is usually a normal or negative sedimentation rate, as well as serologies, and often normal complete blood counts. Treatment usually consists of glucocorticoids and potentially cyclophosphamide, on which patients can have a good response, although relapses can occur and survival is often reduced from expected. This was the focus of two abstracts conducted by Dr. Rula Hajali and colleagues at Cleveland Clinic. In this study, investigation was pursued with regards to two possible subtypes of central nervous system vasculitis, small and large to medium vessel variants. This study compared their features in 34 patients with CNS vasculitis. In examining these two variants, no differences were seen in the clinical symptoms. However, there were important differences observed in other investigations. In terms of MRI imaging, large to medium vessel vasculitis was more commonly associated with brain infarcts, while those who had the small vessel variant could be seen as far as the development of tumor-like lesions or contrast-enhanced lesions. We can also see that large to medium vessel variant were associated more commonly with arterial stenosis, as well as abnormalities on vessel-weighted imaging. And also when we look at biopsies, we can see that this played a particularly important role in the identification of those who had the small vessel variant, although this was also important in those who had large to medium vessel variants. And we can see in both groups that analysis of the cerebrospinal fluid played a very important role. So from this work, we've identified as far as that imaging and evaluation of cerebrospinal fluid are critical for the diagnosis of central nervous system vasculitis. The variants of small vessel versus large to medium vessel can have differing imaging patterns. And brain biopsy, while invasive, can be valuable, particularly in the small vessel variant of CNS vasculitis, and also in differentiating this from other important mimics that can be seen with this disease. Now, another focus of investigation in CNS vasculitis examined vessel wall enhancement changes on high-resolution MRI. In this study, 9 patients with primary CNS vasculitis underwent serial high-resolution MRI imaging. Vessel wall enhancement was analyzed in 17 intracranial arterial segments, where this was classified into 3 categories. In 153 arteries that were examined at each session, about 25% had concentric vessel wall enhancement at baseline. This was observed to decrease over the course of time with treatment, going to 12% at first follow-up and 6.5% at the second follow-up. 2 patients had a flare with new intraluminal enhancement being seen in 5 arterial segments. We can see here on these images on the left here, this area of enhancement. And on these 2 images seen here on the right, we can see enhancement over the right and left internal carotid artery, which has resolved following treatment. So MRI vessel wall enhancement may be useful for monitoring the response to treatment in CNS vasculitis. And finally, ending with my thoughts about the best abstract in vasculitis at the 2020 Convergence meeting. This was the identification of VEXAS. The VEXAS syndrome stands for vacuoles, E1 enzymes, X-linked, autoinflammatory, and somatic. And this was work conducted at the National Institutes of Health. In this study, 28 men were identified who had a somatic mutation affecting the methionine 41 and UBA1, an E1 enzyme that initiates ubiquination. The clinical features that were seen in these patients varied and included fevers, venous thrombotic events, pulmonary infiltrates, chondritis, vasculitis, cutaneous lesions, in particular neutrophilic dermatoses. And most importantly is that there was the observance of hematologic abnormalities. This included cytopenias, increased MCV, myelodysplasia, and in bone marrow biopsy, unique vacuoles were seen, as can be seen in this image, in myeloid and erythroid precursor cells. This was observed to develop in late adulthood, often in the 60s or 70s, and unfortunately was treatment refractory. The reason this is relevant for rheumatologists is that this can look like diseases referred to us to see: relapsing polychondritis, polyarteritis nodosa, Sweet syndrome, Still disease, and giant cell arteritis. How this can be differentiated from VEXAS includes often the development as far as treatment refractory disease, and in particular, the presence of hematologic abnormalities, which if present should prompt a bone marrow biopsy to examine for the presence of these unique vacuoles. The reason that I feel this abstract and body of work has been so important is that this used a genotype first, phenotype neutral strategy to identify the cause of a severe adult onset disease. This was also a novel description of a somatic mutation as a cause of an adult onset rheumatic disease. Most significantly, however, has been the identification of this diagnosis and what this can mean for patients and their families. These are very often challenging diagnoses for which there have been limited and challenging treatment options. And the fact that this has been identified will provide patients with an initial answers as far as first steps, and provide investigators with their first steps in terms of investigating future treatment options for this challenging entity. Hello, I'm Carol Langford from the Cleveland Clinic. We're going to be discussing today the treatment of ANCA-associated vasculitis in 2020. This slide shows my disclosures. Today, we're going to be discussing the approach to the treatment of ANCA-associated vasculitis, including the specific therapies that are used, and in particular, we'll be reviewing novel information presented at the ACR Convergence 2020 related to the treatment of ANCA-associated vasculitis. ANCA-associated vasculitis belongs within the family of small vessel vasculitides. Today, we will be focusing on granulomatosis with polyangiitis and microscopic polyangiitis. Granulomatosis with polyangiitis is characterized by the clinical involvement of the upper airways, lungs, and kidneys in particular, as well as histologic evidence of granulomatous inflammation, vasculitis of the small to medium-sized vessels, and post-immune glomerulonephritis. Microscopic polyangiitis is similarly a multi-system disease which had predilection to affect the lungs and kidneys and differs from GPA in lacking granulomatous inflammation. The current treatment approaches for GPA and MPA are similar, but there are some specific adjunctive measures that are used for upper airways disease in granulomatosis with polyangiitis. Another important factor to consider is the spectrum of disease severity that can occur in ANCA-associated vasculitis. This can range from severe and life-threatening involvement of the lungs and kidneys to active but non-severe disease such as that involving the sinuses, skin, joints, or lung nodules without respiratory compromise. and this does influence our treatment decisions. In 2020, we have a number of options available to us for the treatment of ANCA-associated vasculitis. We think of this in terms of phases, whereby active disease is induced into remission, followed by remission maintenance. We will first look at the induction side of the equation. We can see here all of these involve the use of glucocorticoids. This has some important recent information which we'll be discussing today, given concerns about the side effects associated with glucocorticoids, as well as their impact on patient quality of life. As we think about the induction of remission, we can think of this again in terms of stratification based upon severe and non-severe disease, as we previously outlined. For patients who present with active but non-severe disease, options include methotrexate, mycophenolate, or rituximab could be used. However, in the setting of severe disease, our options include cyclophosphamide, which can either be given daily or intermittently by vein, or rituximab. In considering the data for use, rituximab has been studied in 2 pivotal randomized trials, both published in 2010 New England Journal of Medicine. In this study, the RAVE trial, cyclophosphamide to azathioprine, was compared against rituximab. At the primary endpoint, which was being in remission off prednisone at 6 months, rituximab was as effective as cyclophosphamide, with a similar rate of adverse events and low mortality. This study, while it did enroll patients with severe disease, did have exclusions for the most severe involvement, such as those with a creatinine of greater than 4.0 or those requiring mechanical ventilation. But this did demonstrate that for remission induction, rituximab was as effective as cyclophosphamide. The second trial, the RetuxVash trial, also examined comparison between cyclophosphamide and rituximab. There were some important differences in this trial, which provided us with important information. All patients in this study received 2 doses of intravenous cyclophosphamide, after which they were randomized to either remain on cyclophosphamide or receive rituximab. Patients had no limitations in terms of disease severity, and this was designed as a superiority trial in order to determine if rituximab was in fact more effective than cyclophosphamide. At its primary endpoint, while rituximab was not found to be superior to cyclophosphamide, it did appear to be as effective. It again had a similar rate of adverse events. There was a higher mortality at 18%, which likely reflected the older median age of 68, and that 20% were on dialysis, both of which have been associated with poorer outcome. Now, at the ACR Convergence meeting, we heard some information with regards to the dosing of rituximab. In both of the randomized trials, the previous lymphoma regimen was utilized of 375 milligram per meter square per week for 4 doses. This is different than the rheumatoid arthritis dosing of 1,000 milligrams for 2 doses given 2 weeks apart. And there have often been questions about whether either of these could be utilized. This was the subject of a meta-analysis in which 27 studies were analyzed. And overall, complete remission at 6 months was achieved in 88% of patients, with no significant difference being seen between the 4-dose and 2-dose regimens. There was a similar proportion with infections and death between both doses. So no difference in safety or efficacy was found between the 4-dose and 2-dose regimen. It should, however, be kept in mind that in patients who are of higher weight, there will be a substantially different dosage if the 4-dose regimen was to be used, although the impact of this on effectiveness is unclear at this time. So one question that has arisen is, since rituximab was found to be as effective as cyclophosphamide for remission induction, does this mean that this should always be used in place of cyclophosphamide for all patients? And the answer is not necessarily. We do have to recognize that there is a varying degree of evidence for different settings. The strongest evidence is in those who has had relapsing severe disease or newly diagnosed severe disease, with the weakest evidence for rituximab being in those who had more fulminant disease and were those individuals who were excluded from the RAVE trial. Now, one modality that has been used in patients with more fulminant disease has been that of plasma exchange, and this has been the focus of recent investigations. This work initially was conducted in patients with rapidly progressive glomerulonephritis with the MIPEX trial. This was a randomized trial that enrolled 137 patients who had a positive renal biopsy and creatinine greater than 4.8. All patients received cyclophosphamide and were randomized to receive either IV methylprednisolone or plasma exchange. While the 3-month results were encouraging with regards to plasma exchange, the longer-term results demonstrated that the benefits of exchange were unclear. This has also been utilized in the setting of diffuse alveolar hemorrhage. From a retrospective survey at the University of North Carolina, 100% of patients improved, but these also received aggressive systemic immunosuppressions. From another retrospective series conducted at the Mayo Clinic, plasma exchange did not impact the resolution of alveolar hemorrhage or patient survival. This supported the need to more definitively establish the efficacy of plasma exchange in severe ANCA-associated vasculitis. This was the focus of the PEXAVASH trial, which was recently published in the New England Journal of Medicine. In this study, which was a 2x2 factorial randomized controlled trial, patients with severe ANCA-associated vasculitis, and there was a requirement for either severe renal involvement or alveolar hemorrhage, were treated with cyclophosphamide or rituximab, and then randomized to either receive plasma exchange or not, and then undergo a second randomization where they received standard dose or reduced dose glucocorticoids, where they received a dose of less than 60% of the standard regimen. They were then followed to observe for the composite primary endpoint of end-stage kidney disease or death. This is the largest trial conducted to date in ANCA-associated vasculitis, enrolled 704 patients, 98% of whom had renal involvement and 27% had alveolar hemorrhage. In examining plasma exchange, in looking at the primary composite endpoint of end-stage kidney disease or death, there was no difference between those who received plasma exchange and those who did not. There was also no difference in important secondary endpoints in terms of adverse events or severe infections. So the use of plasma exchange did not reduce the incidence of end-stage kidney disease or death in ANCA-associated vasculitis. There were some important limitations and caveat. As we can see from the hazard ratio, there was a wide confidence interval that crosses 1, so this may not rule out a treatment effect in selected individuals. And the relatively smaller numbers with diffuse alveolar hemorrhage, in particular 8% only had severe alveolar hemorrhage, may impact the ability to detect a benefit of this manifestation. Now, at the ACR Convergence meeting, Dr. Sharon Chung provided a state-of-the-art lecture on the treatment of ANCA-associated vasculitis and discussed a literature review conducted during the ACR Vasculitis Foundation guidelines. In this meta-analysis, the plasma exchange studies, including MIPEX, PEXAVASH, and observational studies were analyzed. This similarly suggested that plasma exchange did not decrease the risk of death. It may decrease the risk of end-stage kidney disease, particularly in those who are at the highest risk. But importantly, plasma exchange was associated with increased risk of infection. So what we can say in total, that the findings do not support the routine use of plasma exchange in most patients with active severe renal disease. Plasma exchange may still be a consideration in severe diffuse alveolar hemorrhage, particularly when the patient is not responding to treatment, or for patients who are at high risk of end-stage kidney disease. But the use in both of these settings must be balanced against the risk. Of note is that plasma exchange should still be used in patients who are dual positive for ANCA and antiglomerular basement membrane disease. Now, what about the other aspect that was looked at in the PEXAVASH trial, which was reduced dose glucocorticoids? At the primary composite endpoint, again, of end-stage kidney disease or death, there was no difference between reduced dose glucocorticoids and standard dose glucocorticoids, and this met the criterion for non-inferiority. Importantly was that serious infections at 1 year were less common in reduced dose glucocorticoids. So reduced dose glucocorticoids were not inferior to standard dose glucocorticoids with respect to end-stage kidney disease or death. There was also a subgroup analysis where patients were examined with regards to the induction immunosuppressive regimen that they received, whether that be IV cyclophosphamide, daily cyclophosphamide, or rituximab. We can see in particular with regards to rituximab that this had an extremely wide confidence interval at 1.86. And while this could favor standard dose glucocorticoids, this was not seen in the final analysis. So at this time, the use of reduced dose glucocorticoids is beneficial and appears to be effective, but we should keep in mind that potential exists for individual response differences that may require standard dose schedules. Now, this issue of trying to reduce glucocorticoids has been an important initiative in the vasculitis investigator community, and that has prompted the investigation of avacopan. Avacopan is a selective small molecule inhibitor of the complement 5A receptor, which has been found to potentially play a role in ANCA-associated vasculitis by driving neutrophil activation. In an ANCA-associated vasculitis animal model, C5R knockout or antagonism stopped the development of vasculitis. Avacopan has been investigated in 2 phase 2 studies. The classic trial, avacopan was added to standard of care, and there was no difference in the rate of serious adverse events. The CLEAR trial examined avacopan in combination with either cyclophosphamide or rituximab and 3 different doses of prednisone. No difference in clinical response was seen between these pre-prednisone doses, including the one in which patients received no prednisone. This then prompted the conduct of the ADVOCATE trial, which was presented at plenary session of the ACR Convergence meeting. In this randomized trial, patients either received avacopan or placebo for avacopan, and this was combined with all patients receiving either rituximab or cyclophosphamide, and then those who received avacopan received a placebo for prednisone, while those who received the placebo for avacopan received prednisone 60 milligrams a day, tapered to off over 20 weeks. There were 2 primary endpoints, remission at 26 weeks and sustained remission at 52 weeks. This trial enrolled 330 newly diagnosed or relapsing patients with GPA or NPA. They had to be positive for proteinase 3 or myeloperoxidase ANCA and have moderate to severe active disease. In the results, we can see that avacopan was not inferior to prednisone for inducing remission at week 26. It met the criteria for superiority for sustained remission at week 52. And the safety of avacopan was favorable. Avacopan may be a future exciting alternative to glucocorticoids in ANCA-associated vasculitis, but further information is needed to understand if this is effective in all manifestations of disease. Now, switching then to the maintenance side of the equation, we can see that we have a variety of different options which have been studied. In terms of conventional immunosuppressive agents, azathioprine was the focus of the first randomized trial to be conducted in ANCA-associated vasculitis, where it was found to be as effective as cyclophosphamide for maintenance. Methotrexate was the initial agent used for maintenance in open-label trials and has been found in randomized studies to be as safe and effective as azathioprine for maintenance. The limitation, of course, is that methotrexate cannot be used in renal insufficiency. Mycophenolate has also been examined in a randomized trial compared to azathioprine, where it was found to have a higher rate of relapse, but this does remain an option for those who cannot take other agents. Most recently, rituximab has been investigated for remission maintenance. In the Manritsan trial, following induction with IV cyclophosphamide, patients were randomized to receive either rituximab or azathioprine. In the 115 patients followed to the primary endpoint as far as major relapse at month 28, rituximab was associated with a lower rate of relapse as compared to azathioprine, although the dosage reduction schedule of azathioprine after 1 year raised questions as to whether this could have made a difference. Long-term follow-up with patients in this trial were pursued over month 60, at which time rituximab was found to still be superior, but following medication discontinuation, relapses continued to accumulate and occurred in 42% of patients, which raises the question about how long to continue rituximab and treatment overall duration. This was also the focus of the Rheumatology trial, which also investigated rituximab for remission maintenance. Differences in this trial was that patients were induced with rituximab, and this also examined a different dose of rituximab, 1,000 milligrams given every 4 months, with the purposes of maintaining B-cell depletion. In this study of 170 relapsing patients examined at the primary endpoint of relapse at 24 months, rituximab again was found to be associated with a lower rate of relapse with a hazard ratio of 0.36. There was a similar rate of serious adverse events, and it was observed that even in this relapsing population, rituximab induced remission in 90% of patients by month 4. So this then was a second study with a different inducing agent that demonstrated that rituximab was more effective than azathioprine to maintain remission. Now, these patients were followed over an extended period of time following the month 24 primary endpoint to observe the rate of relapse and safety. This was followed out until month 48. And these findings were reported at the ACR convergence meeting in which extended follow-up was reported. At the 48-week end of study, rituximab remained superior to azathioprine in relapse reduction. Relapses did, however, occur in both groups once treatment was stopped, with 50% of patients who received rituximab experiencing relapse and over 75% of patients receiving azathioprine. The use of the 1,000 milligrams rituximab every 4 months did not appear to have a sustained effect beyond the treatment period. The number of serious infections was similar between the rituximab and azathioprine groups, and in examining hypogammaglobulinemia, at levels of less than 5, rituximab was associated with 42% who experienced hypogammaglobulinemia, and at the more extended range, as far as IgG less than 3, about 9% of those who received rituximab experienced hypogammaglobulinemia. So rituximab remained superior to azathioprine, although relapses occurred with both once treatment was stopped. The higher dose and more frequent duration of rituximab appeared to offer no advantages in terms of a sustained effect, and no new safety signals were observed, although hypogammaglobulinemia was common. So we can see that different doses and schedules of rituximab have been investigated with the purpose of trying to refine and optimize treatment. And this was the goal of the Manritsan trial, which examined 2 different schedules of rituximab, a scheduled rituximab every 6 months and a laboratory-based schedule whereby patients receive rituximab if they had a rise in ANCA or their CD19 count rose above 0. In these 162 patients who were observed for the number of relapses by month 28, there was no difference in the rate of scheduled rituximab. And we can see, though, that the laboratory-driven schedule reduced the number of infusions. Now, another aspect of this study was that these patients were followed out and enrolled in the Manritsan 3 trial. So those patients who were in remission at the end of Manritsan 2 were then randomized to either receive rituximab 500 milligrams every 6 months through month 18 or a placebo through a similar period of time, with the goal being to evaluate the efficacy and safety of prolonged rituximab in preventing relapses. In these 97 patients who were observed through relapse-free survival at month 28, we can see that there was a lower rate of relapses with those who received rituximab and a longer relapse-free survival. There was a similar rate of serious adverse events and a similar level of immunoglobulin. The main limitation of this study, however, was a possible selection bias based on including those who had previously responded to rituximab during the Manritsan 2 trial. So extended maintenance rituximab through an additional 18 months was associated with a lower rate of relapse without an increase in toxicity. We have therefore seen that we have sought ways to try and identify when to redose rituximab and if there are ways to be able to optimize this. And one of the ways that this has been sought has been through the investigation of biomarkers. This was the goal of two abstracts presented during the ACR Convergence meeting, a study of rituximab troughs done at the University of Kansas, and an examination of B-cell populations done in conjunction with the RAVE trial. While both of these are preliminary and not yet applicable as far as to clinical care of patients, they do support that ongoing work may provide a future means to be able to guide rituximab patients for our treatment in the future. So in terms of remission maintenance in 2020, certainly a question has been, do conventional agents such as azathioprine, methotrexate, or mycophenolate still have a place in maintenance? I believe they do, based on an advantage as far as well-known therapies with an established long-term side effect profile. However, the main disadvantage is that we have seen clearly from two trials that there is a higher rate of relapse compared with rituximab. That said, there are some patients that can do well on these therapies. The challenge is we do not know who these patients are. In terms of rituximab for remission maintenance has a lower rate of relapse compared to azathioprine. The largest body of published data has utilized rituximab 500 milligrams every 6 months for maintenance. The higher and more frequent dose of 1,000 milligrams every 4 months did not appear to offer distinct advantages. And dosing based on Anchorize and CD19 has been used, but the advantage of this is not clear at the current time. The main problem remains that relapses do occur after rituximab has been stopped. Longer-term treatment up to 36 months in studies has been associated with a lower rate of relapse and favorable safety. That said, the duration of rituximab treatment remains unclear, as this is not a 36-month illness where patients can have long-term survival. Concerns remain for long-term toxicity, especially hypogammaglobulinemia, such that refinement of how we use rituximab remains an important point of investigation. So in conclusion, substantial progress has been made in the treatment of ANCA-associated vasculitis, which we have seen reflected in 2020. We have identified more and safer options for remission induction and maintenance, and we have seen reduction in the need for glucocorticoids. There remain ongoing challenges with the risk of relapse, medication side effects, the potential for organ damage, as well as reduced patient quality of life. In future steps, we will continue to see investigation of biomarkers and identifying relapse and helping to identify those at risk of relapse, and also in hopefully guiding maintenance treatment in terms of who needs what and when and for how long. We will also continue investigations to gain a greater understanding of pathogenesis and develop tools for disease activity assessment, which includes patient-reported outcomes. And finally, understanding all of these, we will continue to work on developing novel treatment approaches that will help our patients in the future. With that, I'd like to thank you, and I'd be happy to answer any questions.
Dr. Langford, for the very insightful and informative presentations. We'll go now to the questions. The next question would be inquiring about tocilizumab in a patient with past history of breast cancer, which is totally in remission for a long time. So what's your intake on that?
These are always very difficult scenarios as far as trying to weigh the risks and benefits of these therapies. In this type of scenario, if someone had been in remission for a long time, certainly the first discussion would be in conjunction with the patient's oncologist. And again, it would come down to weighing the risk and benefit on one hand, as far as some of the unknowns about tocilizumab impacting the potential for recurrence, versus weighing the known side effects of glucocorticoids and whether tocilizumab would be able to reduce toxicity in that way. So I think this would involve careful discussion with the patient's physician and, of course, certainly with the patient themselves as far as risks and benefits.
Excellent. Thank you very much. The next question is inquiring about what is the best DMARD for young men with Behçet disease presented with mouth ulcer and severe cognitive dysfunction, mainly memory loss.
Well, I think certainly the question would be, as far as, is that memory loss felt to be related to active central nervous system disease, which is one of the more severe manifestations that can be associated, with poorer outcomes. If there was other evidence to support that there was active CNS disease, you would want to have an agent that did penetrate the central nervous system. Again, the main agents, cyclophosphamide, again, certainly a concern in a young man as far as in pursuing family. And again, there would have to be evidence as far as severe enough disease to justify use of that. Rituximab, there has remained limited experience in Behçet's disease. That is another agent that will cross the blood-brain barrier. Azathioprine and mycophenolate both have the ability to cross blood-brain barrier, but again, I would tend to not use those in the most severe disease. Again, methotrexate does not cross the blood-brain barrier, so that would be an agent that I would not pursue.
Thank you very much. Next question, from your experience, do you think that CNS vasculitis patients should be handled primarily by a neurologist or rheumatologist initially, keeping in mind the initial symptoms and investigation required?
Well, again, in general, as far as once a diagnosis has been established, and that generally does require careful collaborations between the rheumatologist and the neurologist. After that, it becomes a question of treatment. In general, often rheumatologists will tend to be more familiar with the day-to-day management issues as far as the therapies that are used in central nervous system vasculitis. So they will tend to take the lead on prescribing the medications and monitoring the safety. Neurologists remain important in the care in terms of being able to accurately assess as far as how is the patient responding to treatment? And again, that will often be based upon clinical criteria as well as imaging criteria and potentially re-examination of the cerebrospinal fluid. But in general, once a diagnosis has been made, the actual management decisions and monitoring has been done by the rheumatologist.
Thank you. The next question is inquiring about the use of rituximab more than 3 years in ANCA-associated vasculitis. So beyond 3 years, would you try to taper, either prolong the interval or decrease the dose?
Yes, and this is indeed, I think, one of the great challenges that we have right now and one of the main ongoing questions. Because again, we recognize that this is not, a 3-year disease, and this is very much a relapsing disease as well. So in general, my approach is as far as that I will tell patients in the absence of side effects, they can expect to receive maintenance, whether it be with a conventional agent or rituximab, for at least 2 years. And at the end of that time, we look at where we are and where we have come from. If this is an individual who has already demonstrated that they have had relapsing disease, that would be someone that, again, I would tend to continue longer treatment for. Similarly, if this is someone that had experienced severe disease where they had a significant amount of permanent organ damage, whereby another relapse could have significant consequences, that would have importance. Other investigators have also looked at other factors in terms of there have been a higher rate of relapse with those who have been PR3 ANCA positive as compared to those who are MPO ANCA positive, and those who have the phenotype of GPA as compared to NPA, and those may be additional factors. So again, at that point in time, as far as we would look as far as should that patient be continued on every 6-month schedule, consideration of whether that should be lengthened out over the to a longer period of time, potentially as far as whether it should be stopped, or again, even if there would be a role as far as switching to a conventional agent. Now, other factors again would potentially be as far as if there had been other concerns as far as side effects or hypogammaglobulinemia, although again, that is not unique to rituximab and can be seen with other therapies as well.
Excellent. So the next question is in relation to the last sentence you mentioned about hypogamma or severe immunoglobulin secondary to rituximab. Do you support giving IVIG in combination, boluses of IVIG throughout the treatment of rituximab?
So this is an issue that we have become certainly more attuned to, and as mentioned, it is not necessarily unique to rituximab, and some of the times where we have tended to see this more prominently have been those who originally received cyclophosphamide at an earlier point in their diagnosis and have now receiving rituximab. I do measure immunoglobulins to get a sense of where these are running. And again, if we look at what is considered as far as a normal level as far as 700 or above, and a concerning level as far as where there's been clearer evidence of a risk of infections, including severe infections, at being at a level of less than 300. If the patient is between 300 and 700, so they are low but not very low, I then look at as far as has that patient experienced recurrent non-severe infections or a severe infection that has put them in the hospital. If that is the case, then I will generally work with an immunologist in considering whether they should be on immunoglobulin replacement. If they are at a level of 300 or less, then generally those are patients that are considered to be at greater risk, and we will consider more as far as having them on immunoglobulin in conjunction with rituximab therapy. But again, I don't routinely just give immunoglobulin replacement. It would be directed by, again, the level. And then again, if it is a low but not severe level, as far as their history in terms of infection.
Do you use also Bactrim in conjunction with rituximab, especially in the induction phase?
So pneumocystis is an important opportunistic infection that has been seen, actually first reported in conjunction with methotrexate induction, certainly seen with cyclophosphamide, and has been reported with rituximab as well. And this can be a severe infection that can be associated with high mortality. So we do feel that pneumocystis prophylaxis is important. Trimethoprim sulfa or Bactrim has been found to generally be the most effective approach. Not all patients are able to receive this if they have sulfa allergies, in which case other options include atovaquone, pentamidine, or dapsone. So yes, I do use pneumocystis prophylaxis in conjunction with rituximab, particularly when they are on glucocorticoids as well, although there have been some rare reported cases in rituximab maintenance as well.
Excellent. We have room for one more question, and it will be, what is the best option for treating pulmonary artery aneurysm or any large vessel vasculitis associated with Behçet disease?
Yes, I mean, those are very challenging, and some of it does, again, indeed depend upon the location in which this is occurring. Pulmonary artery aneurysms can be very severe and often unexpected, and can be challenging to manage on a non-medical basis. So again, often that would be, depending upon the size, of course, as far as considered a criteria of severe disease where more aggressive treatment is warranted. If there are aneurysms in other large vessel territories, Again, there may be more options where this can be managed on a non-medical basis in conjunction with medical management if this is felt to reflect active disease.
Excellent. Thank you very much. And with that, I think we will conclude the sessions. I'd like to thank you again, Dr. Langford, for being with us and for the very insightful lectures. From here, I'll hand to our chairman of the society, Dr. Hanan Al-Rais. Please, Dr. Hanan, the floor is yours.
Yeah. Thank you all. I'm online now.
Yes, you can talk. Thank you.
Yeah. Coming to the end. Bismillah ar-Rahman ar-Rahim. Wassalatu wassalam ala Sayyidina Muhammad wa ala alihi wa sahbihi ajma'in. Assalamu alaikum wa rahmatullahi wa barakatuh. Dear colleagues and friends, over the past 4 days, an abundance of updates have been presented to you by both renowned international faculty and key opinion leaders from our country. It's my hope that this program has enriched your knowledge skills. As rheumatologists, it's our responsibility to be our best for the benefit of every patient we touch. This is why the organizing and esteemed speakers have worked diligently to prepare and present the best of ACR Convergence 2020 to you. On behalf of Saudi Society for Rheumatology, I want to thank the speakers for their excellent presentation and their great efforts. Many thanks to the chairpersons, and my deepest thanks to the organizing committee and scientific committee for their great amount of work and dedication during the last 4 months. Actually, we are preparing this prestigious meeting, namely Dr. Fahed Al-Anizi, Dr. Abdullah Al-Firej, Dr. Mayada Bawayan, Professor Sulaiman Al-Mayouf, and with Dr. Ashwaq Al-Eid. I would like to thank also the pharmaceutical company for sponsoring this meeting, the Platinum, Lilly, Pfizer, AbbVie, and the Gold, Johnson, and Novartis. Special thanks to American College of Rheumatology for their collaborations with us and being partner in this official Best of ACR 2020 Saudi Arabia. And our greatest thanks to Encore Medical Education and the Vice Stream platform companies for their excellent work. And the good news that all of these Best of ACR lectures are recorded and it will be available at the Saudi Society of Rheumatology website for the SSR members. Finally, our special gratitude and heartfelt thanks for all of you for taking time out of your busy schedule and family time during the weekend and being with us during the last 4 days. We have around more than 800 registered, and in a daily basis, we have a good participation from the rheumatologists, both in the pediatric and in the adult. Until now, we have a good attendees exceeding 200, which is excellent. And I wish you all and your family to stay healthy. And I know all of us look forward to when we can meet together again in person. And I wish we can meet next February between 25 and 29 in the 7th SSR meeting in Jeddah, and also to meet again in the other educational activity. Be safe and stay well. Many thanks again. Thank you.